네, 안녕하십니까. 2025년 하트별 디스 포럼을 시작하겠습니다. 모두 자리에 착석 부탁드리겠습니다. 분들을 진심으로 환영합니다. 저는 이번 포럼 진행을 맡게 된 삼성서울병원 정수련입니다. 우선 포럼을 시작하기 앞서 오늘은 다국적 청중분들의 편의를 위해서 오늘 포럼 기간 동안은 동식 통역 서비스를 제공하고 있습니다. 그 채널 1번이 한국이기 때문에요. 필요하신 분들은 편하게 사용하시기 바랍니다. Ladies and gentlemen, it's a great pleasure to extend a very welcome in the 2025 Heart Disease Forum with the STS. My name is Suryan Chang from Sun Medical Center. I have the honor serving as master ceremony for this forum. To begin, I would like Professor Kyung-Han Kim, is president of the Heart About This Forum, to deliver the opening address, please.
Good afternoon, ladies and gentlemen. I'd like to thank everyone who attended the 2025 Heart Valve Disease Forum meeting. This meeting is premier academic conference that brings together leading scholars from various fields to discuss the latest knowledge on the anatomy, physiology, causes, diagnosis, treatment, and future of heart valve disease in an exceptional atmosphere. Launched in 1998, the Heart Valve Forum is now in its 27 years and its 26th year. This year, we are particularly honored to introduce the new logo. And this year, Professor Ki-ik Sung, Dong-Sop Jung, Suryan Jung from Samsung Medical Center, along with our executive team, diligently prepared the conference with the theme and slogan, the Wonderland of tricuspid valve, unraveling its secrets. And we also thank Professor Junbam Kim and Professor Chris Maleslie for their hard work in consultation with the STS and their contributions to the conference preparations. We aim to provide a forum for scholarly and systematic review of tricuspid valve fundamentals and the latest trends. And this year, we are proud to co-host the conference with the Society of Thoracic Surgeons, STS, with whom we will be proud to partner starting in 2023. And we are preparing for a premier international academic conference by bringing together world-class scholars in related fields. We are grateful to Dr. Vinny Badua and Dr. Chris Maleslie for their dedication and hard work. Thank you. And we are deeply grateful to the founders of Valve Forum, Professor Byung-Chul Chang, Hyuk-an, Pyo-won Park, Jae-won Lee, Nam-sik Jung, and Jae-kwan Song. We sincerely ask for the interest and support of our members so that Heart Valve Disease Forum can establish itself as a world-class academic meeting that sets standards and a healthy future for the diagnosis and treatment of heart valve disease. And finally, despite the challenging times facing the Korean healthcare circumstances, we bow our heads in respect to the medical professionals who are working tirelessly on the front lines of essential medical care. Thank you so much.
Thank you, Professor Kim. And next, we welcome the Professor Binod Badwa, President of Society of Thoracic Surgeons, for opening address, please.
Well, thank you so much. First of all, it's good to be back in Seoul, many friends, colleagues, and I want to recognize first the technical contributions and the scientific contributions from our Korean colleagues. That this partnership between the Korean Society and the Heart Valve Disease Forum with STS is valuable, not just for our presence and STS's presence in Korea, but for our colleagues in collaboration with STS and with the country and the world. The success that's occurred from your contributions, some of you in this room, has helped to elevate the entire specialty, not just at a local level, but at an international level. And I think that's the key value of what we're trying to do together. We're sharing knowledge bilaterally to elevate the specialty for all. And I think this is a unique forum to do that. We've had this pleasure of partnership thanks to the leadership of Dr. Kim, and our founders, who I can see in front of me. I know we're missing a few, but Dr. An, Dr. Park, and Dr. Chung, thank you. I want to recognize you. First, a round of applause for these 4 gentlemen. Of course, I'd be remiss without thanking Chris Malasry, J.B. Kim, and for their collaboration to help us arrive and do this. And I look forward to the ability to do this every year. If we can continue to do this and with the collaboration, I want to recognize the industry sponsors that have helped put this together and the assembly of this whole gathering. It's been really excellent. Every year you're getting better. It's wonderful. And congratulations for the vision in 1998 to create something and creating a legacy for this collaboration. Thank you.
Okay, thank you, Professor Pinati Badworth. Is next. It is my great honor to invite Pyongyang Park Intensive Medical Centers, representing host institution, to deliver a welcome address. Please give him a big round of applause.
Thank you. Good afternoon, ladies and gentlemen. It's my great pleasure to welcome all of you to this symposium. First Heart Valve Disease Forum was held 1998 at Samsung Medical Center. At that time, I was program director in cooperation with Professor An and Professor Zhang. Main topics of this symposium were annual changes to aortic valve, mitral valve, tricuspid valve disease, and other specific titles in valve surgery. In 2002, Heart Valve Disease Forum on Tricuspid valve disease was organized by Yonsei University Severance Hospital. Many cardiologists and cardiac surgeons participated in the meeting because rheumatic valvular heart disease with mitral or double valve disease was still prevalent in Korea. Therefore, surgical management of recurrent severe TR after previous rheumatic surgery and prophylactic tricuspid valve repair at the time of left side valve surgery were real important issue in cardiology and cardiac surgery society. Currently, recurrent TR after previous rheumatic valve surgery is markedly reduced. However, severe TR patients associated with chronic atrial fibrillation increased. The optimal timing and the surgical management, including major procedure, are hard issues in this patient now. I believe this meeting will be a very good opportunity for all participants in sharing their experience and discussing new ideas on tricuspid valve management. Lastly, I'm very happy to see again Professor Badwa, first Vice President of STS board member, and Professor Bowling from Michigan University Medical School. Thank you.
Thank you. We will have a cross introduction by Professor Dong-Sak Chung from the Samsung Medical Center. He's been charging the organizing science program for this forum.
Welcome to this seminar. I'm Dr. Dong-Sak Chung from Samsung Medical Center. Welcome again. So the first day we already enjoyed the wet lab this morning. I'm very surprised that every participant has enjoyed the wet lab with enthusiasm. In the afternoon, the remaining session, we have 2 sessions and 1 special lectures. So the first lecture is fundamentals in tricuspid regurgitation. We invited many other parts, including cardiology and imaging interventionalists. And the second session is about the tailored approach to tricuspid regurgitations. And between the sessions, we have special lectures for researchers. Just a great help to the paperwork. And the second day is that we have 5 sessions and 2 special lectures. The first 2 sessions is about the innovations in tricuspid valve surgeries and interventions. And after coffee break, and the special lectures will be delivered by Dr. Professor Bowling. And after lunch, we will discuss about the various interesting cases, not here, as you can see, so in the seminar 3 on 3rd floor. And then we will have a coffee break, and debate session is ready. To repair or not to repair or moderate functional TL in left-sided valve surgery is very old concerns. I'm waiting for this discussion because I have many interesting about this issue. And then the session will be the tricuspid regurgitation in complex clinical scenarios, including the pacemaker, related tricuspid regurgitation, etc. And we will have another special sections delivered by the Professor Dr. Kim and Dr. Badwar. So the cardiac surgery surgeon's role in tricuspid regurgitation and the impact of AFib ablation on secondary TL in mitral valve surgeries. And the last session is about the contemporary challenges in considerations in valvular heart disease, especially in aortic valve disease. So this evening, the faculty dinner is ready. I hope you will enjoy our seminars and symposiums. Thank you very much.
Okay. Next, we will course introduction by Professor Chris Mollisri, and who is the program co-director in this forum.
Thank you, Dr. Sirian. We're excited to be back here again in Seoul on behalf of STS. I think one of the strengths of this forum is the collaboration with the 4 prominent universities in Seoul and now with collaboration internationally. I think this forum has risen from a national stature to an international stature. I'm really excited to be here again this year in 2025, where it all started in 1998 at Samsung University. We're back here in Samsung again. Congratulations, Dr. Park, on I think one of the hottest topics in cardiac surgery, tricuspid valve. I'm glad to have guest speakers from the United States, incoming President Dr. Vinay Badwar, and innovation, which will be highlighted today, I think is going to be inspiring for both Koreans and also Americans who are attending this. Steve Bowling will be talking about how innovation has affected cardiac surgery and inspired the next generations of cardiac surgeons here today. So thank you very much. I look forward to a very exciting and dynamic meeting.
Thank you. Okay, so before the starting session, as faculty members, please honor in the stages. So we'll take a group photos. Please get in. 지금 찍자고. Okay, as faculty member in this, yes, is gather in front of the stage for take a photos, please.
I'm old, so I have to sit. Oh, I feel very sad now.
Okay, so we will now begin the podium session. The title of the first session is Fundamental in Tricuspid Regurgitation. This session will be chaired by Professor Kyung-Han Kim and Professor Binod Bedwar. We kindly invite our chairperson to proceed this session.
Thank you. 패널 교수님들 앞으로 나와서 앉으십시오. I'd like to call panelists in this session. Please. Okay, let's start the first session. Session 1, the fundamentals in tricuspid regurgitation. I'm Kyung-Han Kim from Seoul National University Hospital, president of Heart Valve Disease Forum, and co-chair is Professor Winnie Badwa from West Virginia University Hospital. And we have 4 speakers, so I'd like to introduce first 2 speakers. And first topic, Professor Jae-woong Choi from Seoul National University Hospital, pathophysiology and natural cause of tricuspid regurgitation, and then a 20-minute talk. Please wrap up your talk around 15 minutes and question and answer. After that, we will continue the 10 minutes panel discussion and Q&A. Professor Choi, please.
Good afternoon. My name is Jae-woong Choi from SNUH Hospital. It is a great honor for me to give the first lecture at such an important meeting organized in collaboration with the STS. Although today's topic is a bit unfamiliar as a surgeon, and I feel somewhat humbled to speak in front of such a distinguished audience, I'll do my best to share a surgeon's perspective on the pathophysiology and natural course of tricuspid regurgitation. First, I will begin by discussing the pathophysiology, classification, and clinical impact of tricuspid regurgitation in general. Then I will move on to the address late tricuspid regurgitation that develops after surgery for left-sided valve disease, which is a condition frequently encountered by surgeons. The pathophysiology of TR can be summarized as follows. Once TR develops, regardless of the initial cause, it leads to volume overload of the right atrium and right ventricle. This volume overload results in dilatation of RA and RV, which in turn causes tricuspid annular dilatation and leaflet tethering, further worsening TR. The aggravated TR then exaggerates RA and RV volume overload, creating a vicious cycle of a progressive chamber dilatation and worsening regurgitation. Over time, this vicious cycle leads to RV dysfunction and ultimately right heart failure. Right failure and TR are regarded as a component of a multi-organ syndrome involving both cardiac and extracardiac structure, such as the liver, kidney, bowels, lungs, brain, and muscles. Typically, systemic congestion affecting the splenic organ is the earliest pathophysiological consequence of right heart failure and TR. In more advanced stage, reduced cardiac output leads to cerebral and peripheral hypertension, and ventricular interpedience contributes to the pulmonary congestion. These processes manifest clinically as dyspnea, generalized edema, fatigue, dyspepsia, and ascites. Tricuspid regurgitation can be broadly classified into 3 categories according to underlying cause. The first is primary TR, which results from interesting valve disease. The second is secondary TR, in which the leaflets are structurally normal, but abnormalities of right atrium, tricuspid annulus, or right ventricle lead to regurgitation. The third is CID-induced TR. Traditionally, TR was categorized simply into primary and secondary types, but more recently, CID-induced TR has been recognized as a distinct entity because its pathophysiology and therapeutic approach differ from other TRs. Primary TR is known to account for 5 to 10% of all TR cases. The causes include congenital anomaly, such as F-type anomaly, infective endocarditis, and disease that infiltrate the leaflet, such as tumor or rheumatic disease, and degenerative change and iatrogenic injury. The secondary TR accounts for about 80% of all TR cases and is classified into ventricular and atrial types. Ventricular secondary TR occurs in setting of left-sided valvular disease where elevated left atrial pressure leads to pulmonary hypertension and subsequent right ventricular dilatation, or in precapillary pulmonary hypertension where increased pulmonary artery pressure directly causes RV dilatation. On the other hand, atrial secondary TR results from dilatation of the right atrium and tricuspid annulus and is most commonly associated with atrial remodeling due to atrial fibrillation. This figure illustrates the normal heart and the morphological changes seen in atrial and ventricular secondary TR regurgitation. The left panel shows a normal heart with a characteristic U-shaped flow from the tricuspid valve to the right ventricular outflow tract. The middle panel demonstrates a typical morphological feature of atrial secondary TR, where marked dilatation of right atrium. The right panel depicts the ventricular secondary TR, which is a result from right ventricular lateral wall dilatation due to elevated pulmonary artery pressure or primary RV disease. Finally, CID-related TR account for about 10 to 15% of all TR cases, and it's estimated the approximately 1/4 of a patient with a pacemaker have tricuspid regurgitation. The incidence of TR has been reported in several recent studies. Since almost all of these studies are based on patients who underwent echocardiography in hospital setting, the prevalence is likely underestimated. One such study was conducted across 10 centers in Spain over a 3-month period, enrolling approximately 35,000 patients who underwent echocardiography. Among them, about 6% had a significant TR of at least moderate degree, and roughly 30% of these patients present with severe or great TR. The cause of TR were as shown in the figure. Among cases of primary TR, CID-induced TR was the most common, followed by congenital cause. In secondary TR, mitral or aortic valve disease accounted for approximately 60% of cases. In 2022, a study from Australia analyzed approximately 440,000 patients using the National Echocardiography Database from 25 participating centers. Among these patients, the prevalence of significant TR of at least moderate severity was 7.4%, which is comparable to the 6% reported in the previous study. Now I would like to discuss the clinical impact of TR. This study, published in 2004, analyzed a total of 5,223 patients and demonstrated that the severity of TR was associated with older age, reduced left ventricular ejection fraction, and increased right ventricular dysfunction. This graph demonstrates that the difference in survival according to TR severity, showing a progressive decline in survival as the severity increased. The approximate 1-year survival rate were around 90% for no or mild TR, 80% for moderate TR, and 60% for severe TR. Multivariable analysis further confirmed that both moderate and severe TR were significantly associated with worse survival compared with mild TR. The study using the Australian National Echocardiography Database, which I mentioned earlier, also evaluated survival according to TR grade. This study showed a similar result. Patients with mild, moderate, and severe TR had a significantly increased mortality compared with the patient without TR. Notably, even mild TR was associated with a significant increase in mortality with a hazard ratio of 1.29, and the severe TR was also associated with much higher risk with a hazard ratio of 3.23. From a clinical perspective, the key question is when to initiate active treatment for TR. Even in cases of severe TR, symptoms may be mild in an early stage, and the patient often responded well to diuretics. However, if a watchful waiting strategy is pursued with early medical treatment, there comes a point when symptoms suddenly worsen and irreversible organ damage may occur. According to a recent published study, among 4,051 patients with at least moderate TL, only about 37 patients showed improvement with medical treatment alone, while approximately 10% experienced progression of disease at 1 year. When these results are extended to 5 years, about 30% of patients with moderate TR progressed to severe TR, and 60% of patients with severe TR remained severe at 5 years. In such a patient, it is highly likely that over time, right ventricular dysfunction is progressing through the vicious cycle of TR pathophysiology described earlier. The survival curves also differed by groups. At 1 year follow-up, patients who remained severe or progressed to severe TR showed worse survival, with a hazard ratio of 1.3 and 1.92 respectively, compared with those who regressed. Even patients who remained moderate had worse outcome, with a hazard ratio of 1.18. In the end, these findings suggest that apart from 37% of patients who showed regression, additional efforts are needed to improve survival in the remaining patients. However, as you all know, the surgical outcomes for TR are far from satisfactory. According to the paper published in 2020, the operative mortality of isolated TR valve surgery was reported to be around 10%. In clinical practice, patients with severe TR but only mild symptoms are often referred late because of concerns about high operative risk. This delay can lead to worsening RV dysfunction and more severe symptoms. When symptoms become significant, intervention is reconsidered, but by then, the operative risk has increased even further, making treatment more challenging. Ultimately, the treatment of TR may require early referral before the development of RV dysfunction and severe pulmonary hypertension in order to reduce operative risk and secure durable long-term outcomes. In 2024, a study using a registry compared to 1,217 patients managed medically with 515 patients who underwent surgical repair. The results show that the low-risk group with a TRI score of 3 or less, both repair and replacement were associated with significantly better long-term survival compared with conservative management. Similar findings were also observed in intermediate risk group. Based on these findings, the authors emphasized the need for early intervention in TR, considering the continuously progressive pathophysiology of TR. This approach appears to be a reasonable strategy. Now I'll move to the late TR, which is frequently encountered by surgeons. There have been many reports on the development of late TR after left-side valve surgery, and our institution also published a related study in 2008. In that study, 335 patients were followed for 11.6 years, and significant TR of moderate or great severity occurred in 26.9% of patients, and severe TR was observed in 7.5%. In addition, significant TR was found to have a markedly negative impact on event-free survival. However, the mechanism underlying the development of TR after left-side valve surgery remain unclear, although it appears to be largely functional in nature. A Japanese study also reported a similar finding. In 370 patients who underwent left-side valve surgery and followed for 9.54 years, the incidence of severe TR was 6.2%, which is comparable to the data from our institution. Although some paper reports suggest that the incidence of late TR is lower in patients with degenerative MR, a recently published population-based analysis showed otherwise. In 153 patients from Olmsted County who underwent mitral valve repair for degenerative MR, the incidence of severe TR was approximately 5% at 10 years. This suggests that late TR may be a common problem following mitral valve surgery, regardless of etiology. Multiple studies have identified the risk factors for the development of late TR. These include higher pulmonary artery systolic pressure, a longer duration from the onset of mitral valve disease to surgery, and atrial fibrillation. The cause of late TR are not fully understood, but several possible mechanisms can be assumed based on risk factors. Long-standing left side valvular disease leads to left atrial dilatation and impaired contractility. This increased the afterload of right ventricle, promoting adverse RV remodeling, which creates a highly susceptible condition for the development of significant TR. In addition, after T-valve surgery, residual TR, remained atrial fibrillation, and pulmonary hypertension may contribute to the progression of TR even after successful left-sided valve surgery. To reduce the risk of late TR, surgical strategies have evolved over time. In the early years, no intervention was performed for secondary TR. Since the 2006 guidelines, concomitant tricuspid valve surgery has been recommended for patients with severe TR. From the 2012 guidelines, concomitant surgery has also been considered for patients with mild or moderate TR when annular dilatation is present. More recently, some surgeons have even suggested prophylactic surgery regardless of the presence of annular dilatation. The study was conducted at our hospital and presented by Professor Kyung-Han Kim at the 2017 STS annual meeting. It analyzed 256 patients who underwent mitral valve replacement and had only mild or less functional TR. The outcomes of those who received prophylactic ring tricuspid annuloplasty were compared with those who did not. At the time, Professor Stephen Bowling, who is with us today, presented a debate in favor of our study. Although supported by Professor Bowling, our study was published in STS rather than ATS. In the ring TAP group, no progression of TR was observed, whereas 10.3% of patients without TAP developed significant TR. Tomorrow, Professor Yoonjin Kang will present the longer follow-up data. There was also a randomized study on similar topic. It included 106 patients with moderate or less TR, although it was a relatively small trial. It clearly showed that patients who did not undergo ring TAP developed moderate or severe TR significantly more often. Let me present the conclusion of this lecture. The prevalence of significant tricuspid regurgitation is approximately 6 to 7%. Tricuspid regurgitation worsens through a vicious cycle of progressive severity, and this increasing severity has a significant adverse impact on survival. The instance of severe tricuspid regurgitation after left-side valve surgery is not negligible, and continued research on tricuspid intervention is needed to prevent and manage this complication. Thank you for your attention.
Okay. Thank you. Now this paper is open to discussion, the question, comments from the floor. First, how about the questions from panels? Maybe you prepared a lot of questions, please. Yeah, Professor Yoonjin Kang.
Thank you for your great lecture, and I really enjoyed the lecture. And about the late TR, you mentioned that the atrial fibrillation is risk factor of late TR. So was there any influence of concomitant Cox-Maze procedure when performing the surgery, like for the occurrence of late TR?
Yeah, the related paper was published in 2005 in Circulation at our hospital. So at that time, the Cox-Maze procedure can decrease the late TR occurrence.
Actually, I have one question to Dr. Bowling. What is the reason of late TR, anatomically or the other issues related? What is your the opinion? The 마이크를 선생님 편에 조금 갖다 주시겠어요? 예, 예. 그거 바로 드리세요. 예.
First of all, that was a fantastic lecture about the pathophysiology of tricuspid, and thank you very much for the organizers again for having me here in Seoul. I would say I live in a very small town. Ann Arbor is very, very small. Seoul is very, very big. And I think of things from a small town. I'm a simple man from a small town. And I will summarize your lecture. TR is bad.
Right.
And second of all, we should find TR and we should fix TR. And I think the mechanism, if you think of it, is the interdependence of the left ventricle and the right ventricle. If you look at the mathematics of the left ventricle, it's shaped like a bullet. And the right ventricle is shaped like a crescent around that bullet. When my patients develop mitral regurgitation, of course, the bullet has to expand, and the crescent expands, pulling the tricuspid annulus apart. That becomes like a broken rubber band. It is now shattered. And even though we fix the mitral valve, that rubber band continues to expand over years. And if we don't fix the tricuspid valve there, we're very angry at ourselves that many years later these patients come back and we have to reoperate them, or they're sick and we don't reoperate on them. You are 1 centimeter from the tricuspid valve. I think what we are fearful about is that we will hurt the AV node, and then we will have a pacemaker and so on. But I think we can avoid that. So at our institution, in many places, and you mentioned that debate between myself and Michael Acker about that, we're very aggressive about fixing the tricuspid valve.
Thank you.
So Professor Choi, it was an excellent summary. Thank you. Good to see you again. So now that we are awakened to the presence of TR and its progression, how has your center and other centers in Korea also awakened to surveillance? So many times, as you noted, the patients either with progressive TR or first-time TR present very late in their course. And with the field moving to progressive intervention at early and earlier stages, even in the literature in the last 6 months, how have you implemented changes to more frequently manage these patients and more frequently get them on medical therapy so as to intervene or surveil earlier?
So I'm not sure for the total information in Korea. In our institution, actually we perform the tricuspid intervention quite early stage. So nowadays, for consecutive year, we did not perform the tricuspid valve replacement. That means we usually the cardiologist refer patient quite earlier, so we can fix the every TR. And so nowadays, when I joined the cardiology conference, nowadays early referrals is quite the cardiologists start to know the importance of early referral to the surgeon. So I think that kind of movement is starting in Korea.
Thank you.
Okay. Professor Park, short question. Yeah.
Thank you for your great lecture. I have a question for you that I think we all surgeons face 2 modes of significant TR for surgical repair. First one is a remnant TR after left-sided valve surgery, and the second one is without history of prior cardiac surgery. So do you think treatment strategy should be differentiated for these cases, or we should focus on only the TR etiology and only the severity of TR?
I think that is also related to early referral. So actually the late TR, usually the patient have a history of cardiac surgery, so the operative risk is a little bit high. But the patient was referred earlier, I don't think the operative risk is not high. So actually we perform the lateral thoracotomy or the beating heart surgery for TR. So I think the important thing is early referral, and so every TR can be corrected, so by surgery, so if the patient condition is not that bad. Yeah.
Okay, thank you, Dr. Choi. Let's move on to the next topic. Yeah. Next speaker, Professor Eun-kyung Kim from Samsung Medical Center. She is cardiologist, And the topic is updates, echocardiography in TR evaluation, and the right ventricular function, please.
Thank you for the introduction. I'm honored to be here and participate in this great conference. Today, as an imaging cardiologist, I'd like to share an echocardiographic evaluation of tricuspid regurgitation in the right ventricle. Before I start, I do apologize. My voice isn't in the best condition due to a cold. Echo is a primary tool not only for evaluating the etiology and morphology of tricuspid regurgitation, but also for assessing the associated with hemodynamic consequence on right ventricle. It also provides reproducible quantifications during serial follow-up, guiding the overall treatment process, including the timing of surgery or interventions. New things we're learning about tricuspid and right ventricle, the classification of it and its morphologies, and the regurgitation quantification, and the visualization of discrete how we functioned. With the expansion of transcatheter procedure for tricuspid regurgitations, echo imaging approaches have also advanced compared to the past. To start with new classification of tricuspid regurgitations, we know that in the past, we described here historically just primary and secondary. The primary disease where the leaflet are affected, and secondary disease where the leaflet looks normal with there's still tricuspid regurgitation and associated with concomitant mitral or aortic valve disease, or often in isolated forms such as atrial fibrillations. But we know this way is too simplistic. It has multiple leaflets attached to the large anterior and posterior papillary muscles, and the septal leaflet has its own papillary muscles, but directly attached to the septum, which make more sensitive what's happening on the left side. So with the complex papillary muscles and chordae attached to the LV ventricle and influenced by the left heart through interventricular interactions, we understand that TR is indeed a very complex disease. So functional tricuspid regurgitation can be divided into two large groups of atrial functional and ventricle functional. In atrial functional regurgitation, echo shows the failure of leaflet coaptation at the annulus plane, secondary to dilation of annulus and the right atrium, and not enough leaflet growths to cover the large annulus. Therefore, atrial secondary tricuspid regurgitation is typically shown in the old age female and patient with atrial fibrillation. And ventricular secondary tricuspid regurgitation occurs because of the increased pressure from pre or post-capillary pulmonary hypertension. So anything going on the left side heart, like other valve disease or prior valve interventions, may actually increase left atrial pressure. So dilated mid-ventricle, which pulls papillary muscles apically, tethering tricuspid leaflet. So the leaflet closure happens somewhere within the ventricle, and coaptation is also poor. So now we have an updated classification of tricuspid regurgitation by valve and right heart morphology that include primary organics such as prolapse, endocarditis, or rheumatic heart disease. And pacemaker or other cardiac implanted electronic device related tricuspid regurgitation now its own category, because not only leaflet but also chordae or papillary muscles can be affected, and atrial and ventricle functional tricuspid regurgitation. These are examples of pacemaker related or other CIED related tricuspid regurgitation, where you see from transthoracic and transesophageal echo views an impingement of leaflet close. So, sorry. These leaflets may become fibrosis, reduction motion, or impaired coda apparatus functions. Another updated information is a variable morphology of tricuspid valve shown by advanced three-dimensional TTE and TEE. We can beautifully visualize multiple leaflets, sometimes 2, 3, or even 4 leaflets. This is very useful for transcatheter tricuspid valve interventions. And we can also get really detailed information about the tricuspid annulus. From multiplane views, we can measure the annular area and even tenting degree. So it's actually very helpful when we want to follow how the alveoli is remodeling over the time. What about the quantitation of the tricuspid regurgitations? PISA quantitation is a common way to measure tricuspid regurgitation, but it assumes a circular regurgitant orifice. But on simultaneous multiplane view or biplane view, it's infrequently circular. It can be elliptical or star-shaped or even more complex. So using a single radius or a single time point may significantly underestimate tricuspid regurgitation. Anyway, it's easy to measure, so we still use it, but we know it's not validated for multiple or non-circular jet. Now, the vena contracta area is a new favorite way of quantifying tricuspid regurgitation, because it doesn't rely on geometric assumptions, and it can also be used after device placement. So the issue is that jets can be temporally variable, so we prefer to integrate both PISA method and this 3D VCA over time. In addition to these two methods, PISA and 3D VCA, which are included in the current guidelines. We also have a volumetric Doppler method. This quantifies regurgitant volume and calculates effective regurgitant orifice area and regurgitant fraction from the difference of left side forward stroke volume and the tricuspid inflow. In a recent study measuring PISA EROA 3D VCA and volumetric Doppler simultaneously, PISA EROA 0.34 corresponds to 3D VCA 0.60 and volumetric Doppler cutoff of 65. 3D VCA and Doppler EROA correlate better with each other than the PISA method. By adding these new parameters, we now have an extended TR grading schemes to massive or torrential tricuspid regurgitation. TR patients often present very late, are underdiagnosed and undertreated, with regurgitation severity is far more beyond current guideline cutoffs. So we recommend extending severity scale. This has been adopted in many trials, and there's now growing evidence for outcomes associated with this extended grading scheme in native tricuspid regurgitation, as well as in transcatheter world. The clinical benefit was more pronounced in patients with massive or torrential tricuspid regurgitation, in particular in transcatheter world. From now, I'd like to look at the advanced imaging of right ventricle, especially 2D strain and 3D imaging, which provide additional useful information about RV remodeling and the severe tricuspid regurgitation. Firstly, RV strain requires no geometric assumption or shortening from one single point. It is less load dependent than TAPC or S prime in the severe tricuspid regurgitation and more sensitive in detecting early RV dysfunction. Many surgical and interventional trials have shown that RV strain is strongly associated with mortality and provide incremental prognostic values beyond FAC or TAPC. We know that the ventricular atrial coupling specifically refers to the relationship between ventricular contractility and afterload. Its most objective metric is the ratio between ventricular elastance as a measure of contractility and arterial elastance as a measure of afterload. And we can measure LV-PA coupling using echocardiography, represented as the ratio of TAPC and PASB. Many data have shown that the LV-PA coupling by echo as a powerful and independent predictors of all-cause mortality in patients with tricuspid regurgitation undergoing surgery or transcatheter interventions, which suggests this ratio can inform patient selection and prognostication following the treatment. Unlike the LV, RV morphology is not cylindrical and changes dynamically depending on pressure or volume overload, making it difficult to calculate the systolic function, such as ejection fraction, using 2D echocardiography. Simple area change like FAC from 2D images can be referenced, but it has clear limitation in reflecting true systolic function. With 3D echo, we can obtain highly reproducible measures of ejection fraction and LV diastolic and the systolic volume and stroke volume using this multi-level and multi-plane auto-tracing system. Since the right chambers in the near field on echocardiography, both TTE and TEE can provide a high quality of images, making three-dimensional echo very useful for comparing RV dysfunction before and after the surgery or interventions. This has been validated in many trials. RV ejection fraction less than 45% by three-dimensional echo was a better outcome predictors than TAPC or FAC. And impaired pre-procedure RV ejection fraction by 3D echo was also associated with higher mortality after the transcatheter intervention. And additionally, recently we are obtaining the information about regional and global mechanics in all the way of RV contractions, where longitudinal or circumferential radial strain, even particularly aerial strain. So now we can measure the regional RV function in detail, which help us understand post-OB or post-intervention RV remodeling and correlation with the clinical outcomes. Today, I talked about the recently updated echo assessment of the tricuspid regurgitation and right ventricle. As interest of TR grows, the number of parameters for evaluating TR and the right ventricle is increasing and evolving. It is very important to understand the advantage or disadvantages of these H parameters and integrate them for accurate disease evaluation and follow-up. Thank you for your attention.
Thank you. Actually, this topic is similar to next topic. So after 2 lectures, we will discuss. Yeah, okay. And the next topic will be discussed by Dr. Badua. Yeah.
Sure, we'd like to welcome Professor Youngju Su, discussing updates on imaging, MRI, in tricuspid regurgitation evaluation, and RV function. Professor Su.
Good afternoon, everyone. I'm Youngju Su from Severance Hospital, Yonsei University, and thank you for having me here. Today, I will be sharing updates on the role of cardiac MRI in the evaluation of tricuspid regurgitation and RV ventricular function. Let me start with an overview of what I will cover today. First, I will briefly review what is already established and what is new regarding cardiac MRI parameters and role. And we will look at how MRI can help in quantifying tricuspid regurgitation severity, as well as in assessing right ventricular volume and function. I will also touch on how MRI contributes to understanding disease etiology and tissue characterization. Finally, I will share some future directions and where I think MRI is heading in the management of TR. One of the key strengths of MRI is flow quantification using velocity-encoded sequences of phase contrast MRI. By encoding perpendicular to the imaging plane, we can obtain through-plane velocity information and measure true volumetric flow. This gives us not only cardiac output, but also the regurgitant volume and fraction across valves. There are two approaches to quantify TR by MRI. The first is the direct method, which measures through-plane velocity directly across the TV annulus. In theory, this should provide the most straightforward estimate. But in reality, TV annulus moves during the cardiac cycle and has a non-planar saddle-shaped geometry. That makes the direct method technically very challenging and less reliable because adjusting the right imaging plane during MRI scanning is not easy. For this reason, in daily practice, we usually rely on indirect method. Here, we calculate regurgitant volume by subtracting pulmonary artery forward flow from bank imaging, from the RV stroke volume from cine imaging, provided there is no intracardiac shunt. This indirect approach is much more robust, reproducible, and widely used in clinical and research settings. Here's a simple example. RV stroke volume by cine imaging is 94.7 milliliter, while the forward volume in the main pulmonary artery by bank is 51.1 milliliter. The difference gives us the regurgitant volume, 43.6 milliliter in this case. Dividing by the stroke volume, we calculate the regurgitant fraction, which is 46%. The threshold for TR severity applied same as in mitral regurgitation, and a regurgitant fraction of 15% or less is considered mild, and above 48% is severe. Now I should emphasize that these cutoffs have not been derived from natural TR history data sets. Rather, using extrapolated data from mitral regurgitation. So they have not been extensively validated specifically for TR, but in practice, they are commonly used. A recent study investigated the association of TR volume and fraction with mortality in CMR TR registry. They used the indirect 2D phase contrast method for TR quantification and revealed that both TR fraction and volume were associated with mortality after adjusting of clinical and imaging variables, including RV function. Patients with the highest risk strata of TR volume over 45 milliliter and TR fraction over 50% had the worst prognosis. This study suggested that the new CMR threshold, which can be used for patient selection in future trials to determine if TB intervention or surgery improves outcomes in this high-risk group. Several years ago, echocardiography-based system have proposed the additional categories to severe TR, massive and torrential. Recent work with CMR comparing 3D echocardiography has provided corresponding cutoffs. For example, TR regurgitant volume above 75 milliliter or fractions above 58% for torrential TR. These patients are at least at the highest risk of adverse outcomes, and being able to identify them precisely help us consider surgery or transcatheter therapy. Another promising technique for TR quantification is body flow MRI. This allows free breathing, time-resolving whole heart acquisition with velocity encoding in all three directions. Theoretically, body flow should provide more accurate and comprehensive flow measurement compared with conventional 2D method, especially given the complex geometry and motion of the TV annulus. However, its application in TR is still limited at this point. Further clinical studies and prognostic validations are needed before it can be adopted. So far, most of the evidence we have for TR quantification by MRI has been built on 2D phase contrast CMR. Studies have shown a good correlation between 2D and 4D flow measurement of TR using both direct and indirect method. However, when we compare body flow CMR with transthoracic echocardiography, we observed substantial disagreement in TR severity grading. While differences in measurement techniques and parameters between two modalities certainly play a role, other factors such as volume status or presence of arrhythmias can also affect the assessment. This raises an important question: which modality should be considered the true gold standard for TR quantification? Currently, there is no definite answer, and more research is needed. Moving on, Cine MRI is the cornerstone of ventricular function assessment. It does not rely on geometric assumptions, and it provides excellent reproducibility. We can obtain end-diastolic and end-systolic volumes, stroke volumes, ejection fraction, cardiac output, and ventricular mass of both ventricles. Importantly, in the context of tricuspid regurgitation, right ventricular volume and function are key factors that guide treatment decisions. Here you can see an example of RV volume measurement with MRI using the disc summation method, drawing area of each slice, making summation of area of each slice and multiplying slice thickness and getting volume of ventricle. CMR is currently accepted as reference standard for evaluation of RV volume and function because MRI uses no geometric assumption, provides clearer endocardial definition, and is not affected by body habitus or acoustic windows. Although it is not frequently performed as CMR, CT can be useful alternative to CMR for RV evaluation, considering practical issues such as arrhythmia and poor compliance for CMR. By CT, 3D threshold-based segmentation method is usually used, and cardiac CT is reliable for measurement of RV volume and function compared to MRI by this meta-analysis. Successful TR surgery can remarkably reduce RV volume and preserve RV systolic function. In addition, successful TR surgery leads to significant rise in LV preload and cardiac index, which may significantly contribute to improvement in functional capacity of patient. It seems that RV volume and function measurement by CMR is helpful for determining optimal timing for TR surgery. Several studies have shown that in severe TR, preoperative MRI threshold can predict postoperative outcome. For example, patients with preoperative RV-EDB index less than 165 4 mm per square meter are more likely to have recovered RV function after surgery in severe functional TR. In similar, patients with preoperative RVEF above 46% have better postoperative results in isolated functional TR. One important limitation of conventional RVEF is that it can overestimate RV systolic function in the setting of severe TR. This is because a large portion of the blood ejected from RV may be regurgitant, not forward flow. So, effective RVEF can address this issue. It represents global RV systolic function, but it is corrected for the amount of tricuspid regurgitation. So it reflects the effective forward output. A recent study showed that among all parameters of RV function, effective RVEF had the strongest association with patient outcomes, even after accounting for conventional RVEF. This suggests that effective RVEF may be a more meaningful parameter for risk stratification in TR patients. Another parameter regarding RV function is RV strain using feature tracking on standard cine imaging. Unlike EF, which is a global measure of function, strain reflects regional myocardial deformation and contractilities. This technique can uncover early dysfunction before EF declines, and several studies have demonstrated that impaired RV strain on CMR is strongly linked to adverse outcomes in TR patients. This adds incremental prognostic information beyond the ejection fraction. In patients who underwent transcatheter TB intervention, patterns of pre-procedural CMR RV strain and dysfunction are associated with postoperative outcome. Poor circumferential strain only became a determinant of adverse prognosis when longitudinal strain was impaired. Therefore, patients with diminished longitudinal and circumferential strain and reduced RVEF, and this patient group showed the worst survival. Another study assessed longitudinal strain of RV free wall on 4-chamber cine MRI in patients with severe functional TR. RV free wall longitudinal strain stratified patients for survival. Using this comprehensive information, CMR can be useful to classify the etiology of TR. In addition, when TR are caused by other cardiomyopathies, CMR can assist accurate diagnosis by anatomic evaluation and tissue characterization. Both of two cases shown in this slide had severe TR, but the case in the upper panel showed global subendocardial LGE and very high ECV fraction on T1 map, and eventually diagnosed cardiac amyloidosis. The case in the lower panel shows marked RV enlargement and severely reduced RV systolic function. Worsening and serrated appearance of RV were noted with some dyskinetic segments. Extensive LGE is noted along thin RV wall, suggestive of fibrous displacement. MRI finding of this case is consistent with right-dominant arrhythmogenic cardiomyopathy. Although a recent study reported that the survival was not significantly different according to the TR etiology after adjustment of other factors, some study based on echocardiography reported that prognosis of atrial functional TR is favorable than ventricular functional TR. This raises an interesting question: could MRI-based phenotyping of TR etiology add further prognostic value? Beyond function, CMR also provides tissue characterization. A very recent study published in JAG Imaging showed that septal fibrosis detected by rate gadolinium enhancement imaging has been shown carry prognostic significance in TR. TR regurgitant fraction increased stepwise with non-ischemic septal fibrosis, and this non-ischemic septal fibrosis was independently associated with mortality even after other conventional risk factors, including age, TR severity, RV dysfunction, and dilatation. Among patients with advanced TR, non-ischemic septal fibrosis is an important marker for adverse right side chamber remodeling and provides incremental prognostic utility beyond conventional risk markers. Besides LG imaging, T1 mapping is a more sensitive modality for detection of myocardial fibrosis and is widely used for evaluation of LV myocardium. However, the application to LV wall is currently limited because LV wall is usually too thin to acquire reliable value with current spatial resolution. Looking forward, several directions are promising. 4D flow MRI allows us to visualize complex flow patterns and measure regurgitation more accurately. One of major hurdles in applying 4D flow MRI in routine clinical practice is the complexity of the analysis process. Unlike the conventional 2D phase contrast imaging, 4D flow data requires multiple post-processing steps, which are time-consuming and technically demanding. In particular, accurate anatomy segmentation and valve tracking are challenging and require significant expertise. However, with the introduction of artificial intelligence, there is hope that these steps could be automated, making the analysis faster, more consistent, and more accurate, and results are very promising. Future risk stratification models will likely integrate multiple MRI-derived parameters, volumes, strain, tissue characterization into a multi-parametric approach. This aligns with the broader trend towards precision medicine in valvular heart disease. Another important role of MRI is follow imaging after treatment. In the TriLuminate pivotal trial, CMR was used in a sub-study to monitor reverse remodeling after tricuspid interventions. At baseline, lighter size and function are compared across the increasing level of TR severity, and right heart remodeling was associated with TR severity with atrial and ventricular volume twice larger in patients with most severe TR. After treatment, larger magnitudes of favorable remodeling for RV, RA, and tricuspid annulus were associated with larger magnitudes of TR reduction. Interestingly, RVEF decreased with increasing levels of TR reduction, while effective RVEF increased. In addition, effective RV increased in the transcatheter therapy group and either decreased or remained constant in the control group. This highlights how MRI can not only guide pre-procedural decision making, but also help us understand treatment effects and longer-term outcomes. To summarize, cardiac MRI is a key element in multimodality imaging for TR evaluation. It provides comprehensive assessment of classic parameters, TR severity, RV volume, and function, while offering novel insights from strain, LG, and T1 mapping. Importantly, MRI helps classify etiology, supports risk stratification, and enables monitoring of treatment effects. By combining quantitative and tissue-based information, it gives us a deeper understanding of disease progression and true impact of therapy. And with emerging tools like 4D flow with automated analysis, MRI is becoming not only more precise, but also more a clinical practical modality. Thank you for your attention.
Well, Dr. Su, thank you so much for that very comprehensive and thorough review of cardiac MRI. We're going to hold the questions and maybe call on both you and Professor Kim from a cardiology perspective as part of the discussion afterwards. So thank you very much, but we'll call on you in a moment. Well, maybe we can get them a handheld mic for the discussion. So next, we've heard all of the elements of how to diagnose and examine imaging, and so our president here, Kwangwon Kim, is going to take us through a comprehensive review of rings, bands, sutures for tricuspid valve repair. Professor Kim.
Thank you for your great introduction. So, a brief introduction of me, and I created a word cloud of the main topics covered in today's lecture using the AI review. And today's contents are from basic anatomy to the results of the annuloplasty related to rings. So the basic tricuspid valve anatomy, especially related to annuloplasty. So normal, the tricuspid valve annulus has a bimodal saddle shape with distinct high points located anteroposteriorly and low points located mediolaterally. And real-time 3D echocardiography showed the complicated 3D structures of the tricuspid annulus. And the annulus of tricuspid valve not visible from atrial view and deeper and 2 mm external to the leaflet hinge. And the highest position aortic segment. And in pathologic conditions and long-lasting TR, the annulus tends to be more planar. And the shape of the tricuspid annulus changes according to the cardiac cycle, appearing most circular during diastole and changing to an ovoid shape during systole. And the annuloplasty ring is designed to accommodate the RV systole. And the two main structures close to annulus is the right non-coronary and right coronary cusp of aortic valve and bundle of His. So annuloplasty is for RV systole. And how about the leaflet anatomy and relationship with right ventricle? The T valve has the 3 leaflets, usually anterior, posterior, septal. The anterior is also called anterior superior. Posterior is the inferior or mural. So anterior superior leaflet is the largest, and it attaches to the posterolateral aspect of the supraventricular crest. And the inferior leaflet is completely attached to the mural surface, guarding the diaphragmatic surface of the AV junction, and have multiple scallops, and each limit the inferoseptal and the anterior inferior commissures. And septal leaflet is one of the borders of the triangular cuff. And the T-valve anatomy laid flat after division of fibrous annulus with the AV axis placed vertically, and cords pass from large anterior papillary muscle to anterior to posterior leaflets, and the posterior papillary muscle, often represented by 2 or more components, give rise to cords that attach to posterior septal leaflets. And this is the inferior and anterior superior leaflet and supraventricular crest. And the variable groups of small septal papillary muscles, cords fan out and fasten to anterior and septal leaflets. So what is this portion? Usually in some textbooks, the commissural leaflet, or some textbooks, posterior leaflet. So if you can check the gray anatomy, this is part of the posterior leaflet, usually called P1 portion, the anteroposterior scallop area. So you should cover the annuloplasty. It is part of posterior leaflet. So this is another study emphasizing variations in posterior leaflet. In most specimens, posterior leaflet had 2 or 3 scallops, providing the further evidence of posterior leaflet diversity. And the posterior leaflet had 1 or 2 indentations, which can be mistaken for true commissures. So the the annulus of posterior leaflet was significantly longer than the annulus of the other two leaflets. Although this finding is not consistent with the findings originally reported by Deloche and associates, the lesion designated the commissural leaflet by those authors was in effect included as a part of the posterior leaflet in their study. So posterior leaflet is wholly mural in its attachment. So let's move on to techniques of annuloplasty, suture and rings. And why repairing tricuspid valve? In a great many cases, pure TR will disappear after perfect correction of mitral valve disease, but this is unpredictable, and not repairing the valve in severe TR results in higher mortality rate and somewhat higher incidence of residual insufficiency. And patients with failure of T-valve repair procedure requiring reoperation have a poor prognosis with higher mortality. And the procedure minimally increases operation time and risk with the advantage of immediate improvement of TR that can potentially leave a salutary effect on post-op hemodynamics and the recovery. So this is a diagram from Carpentier's book showing various techniques for tricuspid annuloplasty. And this classic De Vega suture annuloplasty, two semicircular purse-ring sutures made with the same two polypropylene stitch. And two rows of sutures are parallel, but the sequence of the penetration is alternating so that equal narrowing of the annulus is achieved. And usually starts from the anteroseptal commissure and penetrates the annulus until the mid portion of the coronary sinus. And the Y ring is due to differential annular dilatation. And anatomic studies shows that the dilatation of the annulus does not affect all leaflets the same. The posterior leaflet can increase up to 80% of its normal length. Anterior leaflet can increase up to 40%, and septal leaflet up to 10%. And the sizing of 3D ring, usually the septal annulus size or intercommissural distance. And another tip is the leaflet surface area attached to anterior papillary muscle. So in fact, it means anterior leaflet and P1 segment, not anterior leaflet only. And nearly the same concept for triad, MC3 or contour 3D. Then how to know normal annulus? The related body surface area so varies from patient to patient. The more important is the normal relationship between size. And usually we can check it using the annuloplasty sizer. And after two sutures in commissures, you can check the annular dilatation. And this patient, you can see the annular dilatation. And after ring implantation, the final result. So how to suture in septal annulus? So just retract the septal leaflet and just over the hinge point, not the atrial side, like this. And how about anatomy under the cold triangle? The adequate suture site for septal annulus is lateral half. If you cut this side, you can see the medial side is the mitral valve and coronary sinus area, and the lateral side, this is the adequate suture site. And the suture principle, in the aortic segment, stitch closely to the hinge to avoid damage to aortic root. And in the septal annulus, as I described, stitch closely to the hinge to avoid damaging the his bundle. And another side, 2 millimeter outer the hinge point. Okay. And when sutured in aortic segment, caution is required, as needling too deeply can rarely cause damage to the aortic valve area or aorta. If this suture too deep, and another side, this is the aortic root area. So very, very rarely you can injure the aorta or the aortic leaflet. And ring sutures, when suturing the ring, equal spacing is used there's around the septal leaflet because no need to reduce. And the reduced spacing is used for the anterior and posterior annulus, usually 10 to 13 sutures for MC3 ring, the 9 to 11 sutures for triad. And I'm going to briefly talk about MC3 ring and triad. Yeah. And these are commonly used rings for treatment of functional TR, the bands and rings. And why is three-dimensional ring? As TR progresses, the shape of T valve annulus changes from 3D saddle to the horizontal planar. So the MC3 ring, it is the rigid remodeling concept from the mitral annulus to the tricuspid annulus, and match the shape of the ring to shape of the anatomy and tricuspid annulus, and the downward angle in the septal lesion to help reduce stress on sutures and risk of ring dehiscence. And we published one data, the long-term outcomes of rigid versus Devego annuloplasty. So propensity score matching, the 109 pairs. So the final result is the less TR recurrence in rigid ring annuloplasty, but the T-valve related event was not so significant. And triad ring, you can see the dilated tricuspid valve, the annular dilatation with a relatively normal leaflet. So triad ring is the targeted semi-rigid segment braided sewing ring with flexible ends and large opening area, and it emphasizes shorter dimension, septolateral dimension. So what does 28 stands for? It is the internal transverse diameter. And the ring sizing implantation is similar to triad ring, the MC3. The difference is no sutures in aortic annulus and no or less sutures in septal annulus, and lighter than MC3, not bulky, and usually 9 to 10 sutures for ring implantation. So as I showed, this is septal leaflet and medial and lateral half. Usually MC3 ring starts sutures from here, and the triad starts from here. And let's see the T-valve anatomy in the triad ring implantation. Identify septal leaflet and put the first annular sutures on lateral half. And the second annular sutures in the septolateral commissure area. And the marked area is septoposterior commissure. And you can see the scale of the posterior leaflet. And check the posterior papillary muscle and posterior leaflet. This patient has two scallops, the P1 and P2 only. And you can see the anterior leaflet and anterior papillary muscle and P1 segment. And the checked anterior papillary muscle and anterior leaflet. Remember, the leaflet attached to the anterior papillary muscle is anterior and part of the posterior leaflet. So the marked area is the anteroposterior commissural area, is the uppermost area, usually the uppermost part of the ring, like this. So ring annuloplasty focuses on the anatomical approach of the T-valve annulus, considering differential dilatation, and pathoanatomic knowledge around the annulus is necessary, and MC3 ring and triad ring is designed for the 3D shape of T-valve annulus. And how about results? So a comparison of results, recurrence rate was similarly high when using the Devego or Perigord without ring. However, the fact that TR recurrence occurred in at least 20% of cases after 5 years is a very disappointing result. So it means additional leaflet or in the wet lab session, Dr. Maurice Weil mentioned the papillary number procedure. Those kind of procedure can be necessary. And this paper, the long-term survivor, event-free survivor, freedom from recurrent TR was significantly better in ring group. and a trend toward the fewer T-valve reoperation, and the multivariable analysis, use of an annuloplasty ring was an independent predictor of long-term survival and event-free survival. And the moderate or more TR should not be left untreated at the time of mitral valve surgery to achieve a better midterm clinical outcome. And how about reoperation, the high mortality rate of reoperation of tricuspid valve? And the Carpentier ring annuloplasty significantly decreased the recurrence of TR, hence more superior to the Vega. And result with Carpentier Edwards ring showed little change in TR over time. The Cosgrove Edwards bands showed minimal increase. And the two non-ring annuloplasties, the Vega and Perigard, showed substantial worsening in the late TR. This is the report from Cleveland Clinic. So to summarize, as I emphasized, the posterior leaflet of T-valve is wholly mural in its attachment and can have indentations. And P1 segment is attached to anterior papillary muscle and not part of anterior leaflet. And anatomical studies shows that dilatation of annulus doesn't affect all leaflets the same, and posterior leaflet can increase up to 80%. And when implanting 3D ring, it is important to position the highest point of 3D annuloplasty should be around anteroposterior commissure between anterior leaflet and P1 segment to achieve appropriate annuloplasty effect. And the adequate ring annuloplasty can be done under the base of accurate T-valve anatomy around the annulus. And the long-term survival, event-free survival, freedom from recurrent TR, was significantly better in the ring group. Yeah. And suggestions, although many experts will agree that ring annuloplasty provides overall superior results to suture annuloplasty, there is no consensus and no definite data showing superiority of one specific ring annuloplasty technique over another. Although adequate ring annuloplasty is performed, more than 10 to 15% of patients suffer TR during follow-up. So what is next step? The leaflet procedure, so valvular level, or innovated ring or intervention. So to achieve optimal treatment outcomes for tricuspid valve disease, mastery of valve anatomy is essential. Furthermore, the familiarity with the various surgical techniques available for valve repair is crucial. And while long-term outcomes of ring annuloplasty are generally superior to those of suture annuloplasty, this is only possible with a thorough understanding of the anatomy, and the value of traditional suture annuloplasty should not be underestimated because there's no one answer to solve significant TR. So if you, as a surgeon, want to save a patient with significant TR via surgery, you must go back to basics and make every effort to get the best knowledge of the anatomy of heart and valves. I think David is in detail anatomy. Thank you.
Well, thank you, Professor Kim. So that is an excellent beginning to this very important meeting about tricuspid valves, looking at the pathophysiology, the echo imaging, the MR imaging, and now the fundamentals of tricuspid repair. So thank you for that. I'm going to first open it up to the panel, and if anybody would like to have any discussion, please come. There's 2 mics in the stairwell. Just don't trip when you go up there. But maybe our panelists, if there's any questions, feel free.
Thank you for your great lecture, Dr. Seo. I have a question for the Dr. Seo. And so do you routine perform cardiac MRI for all the severe TR patients? Because as far as I know, cardiac MRI is really expensive. So is that your routine practice to perform cardiac MRI for all the severe TR?
Thank you for your question. Actually, as I know, the surgeons in my institution, they prefer cardiac CT than MRI when planning surgery because Today, I talk about many advantages of cardiac MRI, but CT can also provide crucial information in terms of the anatomic information. So, with CT, we can obtain information about the TV annulus diameters and RV volume, or the detailed anatomy of TV apparatus. The another reason why we seldom do MRI before surgery is that actually in most institutions, MRI room is too busy, and usually taking cardiac MRIs take longer time than the MRI examinations in the other body parts. So hospitals and also MR operating room, they don't want to cardiac MRI so much. And in contrast, many clinicians, including cardiac surgeons and cardiologists, not only from valve part, but also from heart failure, the other coronary artery disease, they also wanted to take their patient to receive MRI examinations. So waiting time for cardiac MRI is too long, but our TR patients, they cannot wait for surgery. So my hope is we can take more MRI examination before cardiac surgery, TR surgery or intervention, but it is still long way to go. Thank you.
So thank you, Dr. So. Maybe we can get a handheld microphone to Dr. Yin Kwang Kim from Samsung, our cardiology colleague, because I'll ask a question of both of you to follow up on this question. So predicting TR and diagnosis in TR, I think we now have a good handle now with MPR and other techniques. But the question is timing of intervention and how to predict negative outcome. So Dr. Su had mentioned defining successful TR surgery and the importance of RV function, particularly when you look at RV end diastolic volume index, let's say over 170. When you have these patients with very large right ventricles, perhaps an annulus that are a little larger than normal, say 5 centimeters, how can we now predict, first of all, defining severity, because unlike on the left side of the heart, when you have low flow, low gradient aortic stenosis, it's very difficult other than the RV PA uncoupling. But for the audience here that may not be as familiar, how do you make the decision at the heart team, at the bedside, at the patient level on we have to be careful about this patient. Maybe this is something that we do a transcatheter or surgery. Maybe we should do replacement versus repair. All around the higher risk RV volume overload, poor RV function patient.
Thank you for important questions. Unfortunately, we are not doing transcatheter intervention in Korea. Maybe next year it will be produced in the Korea. But at the time of decision making for a treatment, we are trying to figure out the reversibility of right ventricle. Some patients who underwent tricuspid surgery, they have suffered from the aggravation of RV function after the surgery. So we are trying to find that patients using comprehensive imaging, echo, MRI, and CT. Among variable parameters, as you comment, I think RVPA coupling index is very important to predict the reversibility or to predict aggravation of RV function or pulmonary hypertension after the surgery. So we routinely evaluate the RVPA coupling and as well as MRI. Yes.
I think for our surgical audience, the surgeons in the room, they have to be conversant with these things. I know we know PAPI because we do a lot of heart failure, but this is another element that should be coming into the evaluation of some of these sicker patients. but both of your contributions were excellent and really helped set the stage for this entire meeting, so thank you.
Thank you.
Professor Kim, so we hear in the literature now that the leaflet, especially for transcatheter therapies, I know we're not doing it in Korea, but our friend Becky Han and others talk about 4 leaflets or 5 leaflets, but you just very nicely outlined that there is not 4 or 5 leaflets, there's indentations, but there's truly only 3 leaflets based on their mural attachment. So how do you help define that between our cardiologists and surgeons talking about things? Because when transcatheter therapies come to Korea, you'll be having this conversation frequently, particularly on transcatheter repair, on trying to pick the leaflets and figuring this out. But the issue is that the imaging anatomy and surgical anatomy sometimes don't correlate, much like we have for the transcatheter mitral therapies. So how do you suggest we have that conversation at the heart team? It has to do with strategy.
Actually, the TR intervention will appear soon, and maybe in the high-risk severe TR patients, those kind of interventions will be tried. I think that usually those cases, the anatomy or the systematic discussions maybe not so necessary, but anyway, we should correlate our knowledge, the T findings, CT or MRI, with our anatomical knowledge. And the most of all, I think the Professor Jae Hyung-gon, he does have an experience of the TR-related intervention or the balloon treatment.
Sure.
So in terms of that, what is your opinion? Yeah. Or are there any discussions? Yeah.
Actually, the talk about that will be held tomorrow.
Good.
And I want to continue the question about the sick patient for the TL. I have 2 questions for Dr. Kim. Recently, many patients are very sick TL patient. We admitted the patient earlier before surgery and try to prehab, try to reduction the volume overall. And you show many values. That means there are no single most reliable factors, echo value, to predict the reversibility of the RV function after TR surgery. In case of the prehab, we try to lose weight about 5 to 10 kilogram before operation, and we frequently recheck the echo. So between the 2 echoes, what can be most reliable value to predict the reversibility of the RV function? That is my first question.
Thank you for great questions. Yes, most surgeons in our hospital say about the prehabilitation like you, and the most reliable parameters, as I saw you, the annulus area, I think, before and after the prehabilitations. The annulus area changes and tenting height changes are closely associated with well-controlled prehabilitation in patients with severe or massive torrential tricuspid regurgitations. Several surgeons in our hospital say that the annulus reduction just before surgery may help their technically easy correction of tricuspid regurgitation. So I think the annulus area change is very important parameters among various TR parameters. Yeah.
As a surgeon's viewpoint, the annulus reduction help us to repair the patient. Initially, we plan to replace the valve, but after prehab, annulus can be reducted, and then we can apply our repair strategy. My second question is there any single predictive value for the patient? This is too sick to operate, to repair TL. I mean, if the patient has severe pulmonary hypertension, their uncontrolled left ventricular disease, poor ejection fraction, and severe TL, and huge annulus, in that case, have you ever recommend this patient is too sick to fix the valve? Is there any comments on that?
That is very important point, and I think the clinical findings is more important than echo findings to decide surgery or not, especially multi-organ dysfunction in the severe TR patients like liver damage or chronic kidney disease. In that case, the prognosis after the surgery might not good. As I know, but I think as I commented earlier, the PAPI score, yes, the RBPA coupling index is very important predictor to predict after side effect, after complication or bad outcomes, the surgery, and I don't know, but the strain, maybe the 3-dimensional freeware or longitudinal strain are also closely associated with mortality in recent data, so it will have to predict post-operative outcome, I think.
As you know, not many hospitals, they supply the strain, value of strain and RBPA coupling value to surgeons. So I hope you make some discussion to colleagues, and please.
Sure, I will advise to your hospitals, cardiologists.
Okay, I think
we're almost at time, but I think the surgeons here, the whole teams are gonna start to see a tsunami of these patients, as we have in the United States. Once the availability of transcatheter therapies, these people will come out of the woodwork with cirrhosis and terrible RV dysfunction. But paradoxic septal motion is probably the easiest for all of us to identify, and stay away from those patients if you can. Dr. Bowling, very quick question, and we'll have
Two quick comments. One, as surgeons, we want a number to say, don't operate on this patient. I think that's a little bit too simple. When we prehab the patients, which is a very important point, they get better and we operate them. And it is a little problematic to see which ones will do. But we want that number. 7, below 7, I don't know. Don't operate on them. We want that, but I think that's too easy. The other thing is, Dr. Kim, you gave a beautiful lecture. Thank you very much. I'm a very old surgeon, and I've done about 4,000 tricuspids. And I have looked at them by imaging with my eyes, and I've never seen a tricuspid that didn't have 3 leaflets. So this whole thought that it may be 5 or maybe 7 leaflets, and I know those of us who do percutaneous things, we hear this. There are only 3 leaflets in the tricuspid valve. Thank you.
So as always, Dr. Bowling is pragmatic and very specific. But this field is not specific, and I think the whole day will be about trying to determine how to interpret imaging, how to interpret physiology and technique to get the best results. So this is a very good opening session. Dr. Kim, the co-moderators and panelists, thank you very much. But it's a good opening to the meeting. Congratulations.
Thank you.
So we thank you for the good panelists and session in speakings. We will now take a short coffee break. The next session will be beginning at 3 p.m. Coffee is served at booths on the first floor and the same floors. Please take this opportunity to join the refreshments. Thank you.
가세요. 아, 네.
좀 편한데.
We're transforming futures. We're transforming futures. We're transforming futures. We're transforming futures.
This opportunity to share the charm of this city with the people around the world. I hope a lot of people can experience the beauty of Seoul.
I appear as a dreamy character, a moon rabbit, who loves Seoul.
She observes the city through a telescope and explores the many layers and hidden gems within it. Through this character, I wanted to share the way I see Seoul from a softer, more imaginative perspective. At first glance, Seoul looks like a city full of skyscrapers, but if you look closer, there are so many more peaceful, nature-filled places too. And one of my favorite things to do is walk along the Hangang River while listening to music. It's one of the few moments I can fully unplug, even in the middle of the city, and just focus on myself. Seoul is always on the go. It's constantly evolving, which makes it feel really mysterious and exciting. During the day, you can see this sophisticated modern energy flowing through everyone and everything. But at night, the city transforms, the lights come on, and somehow there's this vibrant, almost this magical energy in the air. The contrast is what makes Seoul feel so unique to me.
Okay, so now this session is the first special lecture in this forum. This session will be chaired by Professor Byung-Chul Chang and Chris Morris. Please.
Good afternoon, distinguished guests, ladies and gentlemen. We will start special lecture 1 for research methodology and practical applications of the STS database. My name is B.C. Chang from Cha University, and my co-chair is Chris Malesri from Chicago University. It is my great honor and pleasure to introduce Dr. Chiyoshi Kaneko. Is it correct? Chiyoshi Kaneko. And he is Everett A. Graham Professor of Surgery in St. Louis, Washington University in St. Louis. He was graduated, he had graduated Keio University in Tokyo and trained for adult cardiac surgery, including aorta surgery in Duke University Hospital. It is my great pleasure to have Dr. Kaneko. Please, you start.
Thank you so much for the introduction. I have the opportunity to talk about research using the STS database. A lot of you probably have seen some research papers from STS database, and I'm going to talk about this. Again, not the most sexiest topic, but I'm going to try to make it as interesting as possible, so please bear with me. Okay, so these are my disclosures. So the goals of the STS Adult Cardiac Surgery Database. It's got tripartite mission from the database. Number 1 is to analyze the outcome. Number 2 is quality improvement and patient safety. A lot of you have seen the star rating system as well as the STS risk scores. And then number 3 is to do a research. So right now, there are a total of 1,010 participant hospitals in the United States that reports to STS Adult Cardiac Database. There's over 35,000 surgeons that report to this. So there's a lot of data within this STS database system, especially in the adult cardiac. It's definitely the biggest compared to general thoracic and pediatrics. And these are the total procedures and index procedures that are counted. So in annual basis, there's 300,000 cases that are being reported. And also, this is in 2023, there's over about 230,000 index procedures that are being reported. So interestingly, there's over 9 million adult cardiac surgery procedures that are captured since 1989. So again, we have a lot of data that we can utilize for this research purpose. And STS database captures over 97% of all adult cardiac surgery in the United States. Again, this is 3 metrics that we're looking at: the center penetration, what's the percentage of centers that are being reported, patient penetration, what percentage of patients are being reported, and the completeness. You can see the numbers there. They're very, very high, meaning that these surgeries are captured in the United States by the STS database. And the most interesting part of this is that this is not mandatory. The government does not mandate this, and people do it because of the quality that is very, very important for the hospital system to report. We report to STS. That is very, very important metric for the hospitals to say that you can do it. So the research platform, there's 3 big buckets of the way that we do research. And again, this goes into a little bit of detail, but I thought I would introduce. I'm the AMP task force chair, but this is what we call a STS-sponsored research. So there's 2 cycles per year. We accept about 4 to 5 projects, and the STS Research and Analytics Center performs the analysis. The second format is called PUF, Participant User File, and what they do, they have a different task force, but what they do is if the PUF file is accepted, the de-identified data is sent to the institution. So the STS does not do the analysis. The analysis is done at the own institution, but they have to show that they have a PhD biostatistician in order to do these analysis. And based on how much data counts we send, there is a cost that actually happens. The STS-sponsored research is free. PUF, you have to pay. And it is sort of a win-win for both parties. For the facilities that you want to do research, PUF has a little lower hurdle, and you can actually purchase those data. The STS actually gets a little bit of money. And there's also a third arm called externally funded research program. I'm not going to go into this too much, but this is usually for external grants and funds. They ask for a data so that they can submit the research grants. So I've looked at the published projects since 2018 up to 2024. These are the number of AMP projects. Again, these are the free STS Research Analytics Center projects. We've done somewhere about 10 to 4, but you can see that it's gradually coming down. It's settling somewhere between that 6 to 8. And some of the decreased numbers in 2023 and 2024 were the linkage to the CMS, which I will talk a little later. Contrary to that, the PUF file has been increasing dramatically over the years. And this has to do with the different cycles and not set numbers of the projects that are being approved. So PUF really opened up a research pathway for a lot of researchers that are participating in the STS. And what's the published journals of these articles? The one that is published the most is Annals of Thoracic Surgery. Of course, this is STS research. So there's over 80 publications in Annals of Thoracic Surgery. But when you look at it, there's a lot of high-impact journal publications, such as JACC, Circulation, JAMA Cardiology. These are all impact factor over 10. So we are producing a lot of high-impact papers from this STS adult cardiac surgery research. So one of the criticism that these registry research will get is that when you look at the strength of evidence, a lot of you have seen these strength of evidence, the STS database research does fall into the case control studies. So there are cohort studies, prospective studies, and then randomized control studies, which are a little higher power compared to these STS registry research. However, these RCTs and cohort studies, you have to ask a very specific question. It involves a lot of cost to do these research and also time. A lot of these are prospective studies. So if you want a 5-year outcome, you need at least 5 years for those outcomes. So there are a lot of positives to these STS research, and I'm going to try to convince you with some of the strength that the STS research has. So number one is the national trends and outcomes. So these are 2 papers for the past 2 years. You can see Dr. Van Balmos's name as a first author in the 2023 paper. So what this does is it shows sort of the trends and the outcomes of index cases over time. And I will emphasize that no other database can actually provide this. There are other databases like Medicare database or national inpatient samples. Those cannot capture all the cases. Remember, the STS captures 98% of completeness. So there's a lot of things that we can analyze. Let's look at some of the things. I know that this is a valve meeting, but the coronary bypass is the most common procedures performed in the United States. So 54% of cases in adult cardiac surgery databases is CABG. And when you look at some of the demographics, all the way on the bottom, the multi-arterial graft use is still very low, 15.9%. And also, we can see what are the minimally invasive CABGs that are being performed in the United States. And you can see that there is a rise in the use of robotic CABG, although the overall numbers tend to be relatively low. So some of these trends are something that other databases cannot really show. So this is one of the strengths. Looking at aortic valve replacement, some of you have seen this slide. I think I've shown this 2 years ago when I was here. Looking at the aortic valve universe slide. How many TAVRs are being performed compared to how many SAVRs are being performed? We can link the data to TVT registry and we can actually create these trend slides. And it really shows that there's a dramatic shift in treatment of patients with aortic stenosis towards TAVR. Also, some of the other bullet points here are shown during the pandemic with relative decrease, but after that, the volume, both TAVR and SAVR are increasing. You can see the trends, and you can actually see the effect of COVID that had to these SAVR volumes. And some of the demographics are changing within the SAVR. You can see that the overall age and the STS score for SAVR is decreasing over time. And also at the same time, the root enlargement in bicuspid anatomy is increasing over time. Again, these are some of the trends that we capture. These are not the randomized control studies, but very, very important to see the trends of the studies. How about TAVR explants, which has been the fastest growing surgery in all cardiac surgery, as well as some of the root enlargements? You can see that these trends are going up. And also aortic valve repair and Ross procedure is increasing as well. Changing gears to mitral valve repair, you can see that the repair percentage by etiology, the degenerative pathology, we're repairing more rather than replacing. But contrary to that, ischemic pathology, we are replacing more than repair. That probably has to do with the CTSN trial that was published in 2020. And also, we can actually take a look at the technique, which you really cannot do with other studies. So you can see that the mitral valve repair technique in the US is changing. We're using more and more neocore repairs compared to leaflet resection. The percentage is about the same. So you can see that there has been changes over the years of the repair techniques in the US. Again, this is the only database that can capture this. How about the treatment of atrial fibrillation? Patients with preoperative atrial fibrillation, the percentage of repairing those have been extremely high, unfortunately. There's about, in 2026, about 40% of patients were left untreated. This is a red dotted line. And in 2022, that percentage has come down to 30%, but you can still argue that treating preoperative atrial fibrillation almost has to be near 100%, but we're not accomplishing that at this point. The weakness of the STS study is that the STS follow-up is limited to 30 days. So contrary to the TVT registry, which is the TAVR registry, they do follow up to 1 year, but the STS only captures up to 30 days. So to overcome this weakness, there's been several linkage to the other database that's been performed. One is to the Medicare database. The problem with this is it's only limited to patients over the age of 65. So the younger patients cannot be linked. So the other initiative, Dr. Badwar was heavily involved in this, was the linkage to National Death Index, which is administered by the CDC. And this allows us to look at the mortality in all patient population, not just patients over 65. So one of the studies that use this is this low-risk SAVR trial. So the second point is that the STS database can be utilized to set the benchmark for some of these studies. This was a study looking at all aortic valve surgery, but after looking at a lot of exclusion criteria, they came up with a low surgical risk AVR. This is comparative to the TAVR low risk population, TAVR and SAVR randomized control low risk population. And what they showed was that the 5-year survival was 92.9%, meaning that it was very, very good. So when you compare this to the TAVR trials, this is looking at the Partners trial and the Evolute low-risk trial, just looking at the surgical arm. This is the Partner 3 surgical arm, and you can see that it's very similar to STS surgical outcomes up to 4 years. But when you look at the Evolute low-risk surgery, you can see that the 4-year outcomes were quite different compared to the STS risk population. So was the low-risk definition on the Evolute trial really valid? I think you can set the benchmark and question some of these randomized control study using the STS database. That's a second strength. This is our own paper that we did back in 2023. This is linking the bicuspid SAVR outcomes with CMS. And the outcomes, even after risk adjustment, was better than the tri-leaflet valves. This is the Notion 2 trial, which compared SAVR versus TAVR. But this is the subgroup analysis looking at tricuspid aortic stenosis and bicuspid aortic stenosis. And when you look at the death, stroke, and rehospitalization, bicuspid aortic stenosis, surgery had better outcomes. And this can be supported with the STS data that we published, showing that the long-term outcomes in these patients are very, very good. Number 3 is challenging the guidelines. This is the guideline from 2020, ACC-HA guideline, looking at the valve choice. So the class 1 indication is shared decision-making. But there is also a class 2A recommendation looking at the age. So in this ACC-HA guidelines, patients under 50 without anticoagulation was recommended for mechanical valve. 50 to 65 was mechanical or biovalve. This was a study, Mike Bowdish presented this at the STS, looking at biological valve versus mechanical valve. This was linked to National Death Index and also propensity matched. And after propensity match, what they showed was that mechanical valve had a benefit at age under 60 years old. So anybody under 60, that benefit of mechanical valve became statistically significant. What's very striking is that there was a ESC-EACS guideline that was just published 2 weeks ago. And in that guidelines, this publication was reflected. And now for aortic valve replacements, mechanical valve is recommended, class 2A recommendation, but is recommended in patients under 60. If you remember the previous ACC guideline, it was 50 years. So this is, again, shows the power of the STS database changing the guidelines, challenging the guidelines. Number 4 is setting the standard of practice. Again, this is a valve meeting, but this is an intraoperative TE at the time of isolated CABG. This was a paper from Johns Hopkins that did this analysis, which showed that the usage of TEE during the CABG was increasing. What they really showed was that the outcome was better if you use TEE. And it was more specific if the patient was intermediate risk or high risk. So in those populations, TEE should be done. Again, this is setting the standard of practice. So a lot of places now perform intraoperative TEE for these CABGs after this report was published. Number 5 is defining quality. So mitral valve repair. This is Dr. Bodwar's paper. This is revising the previous mitral valve surgery risk model. This was based from 2011 to 2016. So what this paper did was looking at all the DMRs from 2014 to 2020. And what was really striking about this trial, or study, was it was an intention to treat analysis, meaning that if the patient went for repair but ended up with a replacement, that also was included in the study. And the conversion rate was 6.4%, and the conversion patients had worse outcome compared to repair. We would sort of predict that. But again, the previous models only used the repaired patients, didn't have that conversion patients. And I think the other important part was the mortality risk for mitral valve repair was 0.43%. So it's less than 1%. Not only that, it's less than 0.5% for these median risks for mitral valve repair. And again, this is really defining the quality. And again, I think it's a powerful tool when we are discussing the options of transcatheter mitral valve repair versus surgical mitral valve repair. Number 6 is challenging the dogma. So isolated tricuspid valve surgery. Finally, the theme of tricuspid valve comes here. But this is using a national inpatient sample. For those of you who are not aware about this, this is a US healthcare database that samples about 20% of entire billing codes. And when they chose the isolated tricuspid valve surgery, the operative mortality was 8.8%. So the consensus amongst the cardiovascular space was that isolated tricuspid valve surgery has very, very high operative mortality. That's the dogma. So this was the study that was done by Vino Thurani, trying to create a risk model for tricuspid valve surgery. And they looked at over 13,000 patients with isolated tricuspid valve surgery. And what they found was that tricuspid valve repair, the mortality risk was 5.5%, replacement 5.7%. So again, it's not low, but it's not as high as people were speaking. And even more importantly, a lot of the mortality, stroke, renal failure, all these complication risks are going down over time. The only thing that was going up was short length of stay, less than 6 days, which is a good thing. So we are getting better at this isolated tricuspid valve surgery, and it will be very, very interesting to talk about this throughout the meeting. Lastly, raising new questions. We spoke about the TAVR explant. Dr. Fukuhara's here. He did the PUF file analysis and showed that the isolated SAVR with TAVR explant mortality was 13.9%. When you do it with concomitant procedure, the mortality was 23.8%. So very, very high mortality after TAVR explant. The question was raised through using the STS database. Similarly, Joe Chikwe's group published the mitral valve surgery after MTIR, the mitral clip. And what they showed was that 95% required replacement. Only 5% was able to be repaired after mitral clip. And the mortality was 10.2%, despite the STS score being 6.5. So again, these are some of the new questions that are being raised using the STS database. So what is the future of the STS database? So future direction, I think linkage to National Death Index is done in only certain cases. So hopefully this will be utilized more to provide long-term outcomes in some of these patients. Again, the weakness of the STS database is that it's limited to 30-day outcomes. So the need for the long-term outcome has to be accomplished through a linkage to another database. Number two is expanding some of these research questions to early career faculty. Again, this requires mentorship. Some of the people think that the STS research is owned by a group of surgeons that are really facile with this research. And I think we really have to expand it to the early career faculty or to the broader audience. And lastly, I think this is a very, very touchy question, but linkage to the TVT registry, which is the transcatheter database, to allow studies looking at transcatheter and surgical therapies is a must for the future. And I think that's the direction that, that the leadership is aiming to accomplish. So I think that's it, and I hope everybody sort of understood the importance of the STS database. It's not all about randomized control study. I think it has a strong, strong power to change a lot of things, and I'm happy to take any questions. Thank you so much.
Well, thank you very much, Dr. Kaneko. Well, we heard from Dr. Kaneko about important application of STS database and practical use of this database in the near future for further progress of cardiac surgery program. We have two important panelists who are working with the Korea Heart Valve Surgery Registry, and we have a lot of questions and support from your database. Can you have any questions? Lee, Sung-Hyun Lee from Severance Hospital.
Thank you, Kaneko, and your great talk about the very fine and well-organized STS database. We have a very small registry system in Korea. It was established in 2016. It also was organized firstly Professor Chang, and after that we collected 20,000 data sheet from in our society, and for annually maintain cost is around $50,000 for that kind of registry system. However, we have to defend just the volunteer system, so not many surgeons don't want to input for their own data to this registry system. So I think like this STS database system, a kind of multi-institutional data system. The most important thing is the accuracy and the coincidence for maintaining the quality for data. So do you have any strategy for reward or some penalty for input your cardiac surgeon's data in US system? So it's my first question. And what is the main budget for maintaining this STS database system? Is it from the government or your Cardiothoracic Surgery Society or some specific organization?
Yeah.
It's my second question.
No, those are great questions. I'm gonna try to answer as elegantly as possible. But I think the second question is very important. How do you fund them? And a lot of these data are inputted by the facility. So we have some of the research nurses or coordinators that actually put those data in. And it is the site's responsibility to do so. There is no punishment, but there is an auditing process trying to look at the outcomes with linkage to the other database. So there's, they don't have an active audit, but audit linking with CMS and looking at the outcomes, which has been shown that the mortality correlates 99.99%. So, a lot of these data are somewhat audited, but it is on the site's discretion and their integrity to make sure that the correct data that are placed. I think answering the first question might be a little hard. I think the STS is linked to also the quality. I think that linkage to the quality is the main portion of people wanting to participate. I sort of mentioned it in the beginning portion. And also creating that, not mandatory, but people wanting to participate in the registry allows more data collection. And that allows more opportunity to do research. And I think this PUF file also creates some sort of a money revenue that can be utilized to keep the database and pay the statisticians that they have. I think there's a lot of factors that are being involved. Vinay, I don't know, you might be able to answer this more elegantly than I can.
Well, you did a nice job. Thank you. Dr. Lee asks a very difficult question, but it depends on the site in terms of the cost. There is a few $1,000 annual participant fee by each participant, and the participant is defined by any hospital or a large group of surgeons that's a rare, but it's usually a hospital. So that's the definition of a participant. So it's not an exorbitant amount. And those dollars, the STS it's not here to make profit and things. It goes back into the actual system to be able to do all of these other elements in terms of quality production and policy, et cetera. But the largest cost is actually the data entry, the data burden, as they say. Roughly one FTE or one person per 400 cases. That's usually the ratio based on the data elements. That said, the STS has been committed over the last 4 years to decrease data burden. In fact, in the latest versions, we decreased the number of variables by 30% in the adult cardiac database. And you'll soon see, it's still soon, but we've been working on an automatic data abstraction process that may potentially decrease that by a market amount to automatically abstract from the medical record, to even decrease the cost at the local site. But foreign countries, we have accepted many foreign countries, either as the entire country or individual sites to participate, and the benefit back is that your participant site, let's say Severance Hospital, will have a comparison to all of the STS database. So your quality production will be compared to, 3,800 participant hospitals.
Well, as far as I understand, the TV captures in STS is over 97% at this time.
Mm-hmm.
In 2020, it was only 40%. Can you say how can you improve the database captures?
40% in Korea?
No, 2020.
Yeah. 2020 is a little bit of an off year because I think it was COVID year. And the number of cases overall went down.
Oh, I'm sorry, 2000, the capture TB was ratio was 40% in STS database. Is it correct?
I don't know if it was 40% at that time. I don't know if we can pull up the slide.
Was the beginning slide?
Yeah, I think it was the beginning of, started in 1989. So, in the beginning, not everybody participated, right? But I think it was that growing progress of more centers participating, maybe at the phase that Korea is seeing with the valve database. But I think it was an effort to show the importance of quality to the community. And also the hospital really recognizes the importance of STS reporting, because if you're not STS reported, if your outcomes don't come up on it, it means that you're not really a trusted hospital. I think it is at that phase. So that's how the percentage increased over time.
I see. Yes.
Yeah.
Dr. Kim?
Great talk. I have a couple of questions, and then I want to be more specific with regard to the cost burden for maintaining the STS database form. For example, how much do you spend money for a year in WashU University and Northwestern to maintain that report form?
Yeah, so we have 3 data abstractors that we pay for. And they're research coordinators, they're not nurses. So they're coordinators, and 3 are dedicated for the STS. So Dr. Badwar said about 400, 1 per 400 case. We do about 1,200 pump case, so that equals to 3. So the math is about right.
Where does the money come from to support full-time 3 employees for that job?
Yeah, that position at WashU is supported with the clinical trials. So they're also participating in other clinical trials as a research coordinator.
Okay, if you don't have such a clinical trial supported by kind of companies, small centers, then how do they manage to maintain the STS data form? Because we have a real problem establishing and solidifying the heart valve registry, and we are confronted with the lack of sufficient manpower to input the data. So please share your kind of strategy to...
again, that's our site, but there are other places where the hospital supports that person because, like as I mentioned, participating in this STS database is so important from the quality standpoint and the reputation of the hospital. They have to maintain that database, right? So that's why the hospital supports that person for the data abstract.
Yeah, great. Second question. So when I see PUF is interesting, so is it available to foreigners like me? And how much, if so, how much is it to get the data? So good enough data for this kind of retrospective research.
Yeah. STS members are able to submit.
So,
was it? PUF? Oh, PUF is participant user file.
Yeah, PUF,
yes.
yeah.
You have to participate.
Yeah. So you have to be participating. Unfortunately. But the cost is somewhere between 50 to 100, depending on the proposal.
I'm sorry. Yeah.
Do you have any also selection system? For example, if there are too many outliers for specific topic for making good paper,
yes.
And do you have any selection system or some team for selection that authorship? Okay.
Yeah. So I think there's 2 mechanisms. One is that we prohibit overlapping with the previous project. So if the topics seem to be overlapping, those are automatically excluded. And the second mechanism is for the AMP task force when we do the meeting. As a matter of fact, I think we're going to have 19 proposals that we have to review at the next cycle. But Chris, be ready. So when we do this, we sort of select the topics that are not really targeted in the past. I think we can direct it that way in the task force meeting as well. So there are a couple of mechanisms to prevent that.
My next question is about the quality maintenance system. So is there any supervisor system for correct data input or some missing data or some incorrect data?
Yeah.
So randomly pick up some specific institution, and do you have any check regularly or some institutions data or not?
Yeah, so that falls into the category of auditing. There are some other databases where they go specifically to the site and then looking at what the data abstracts were correct or not. But for the STS, they usually use the CMS, and then they link it to that and see if they're correct.
Yoshi, thanks for a great talk. You showed the pyramid of importance of research. And I disagree with that pyramid because I think the database provides data that's not just case controlled, but it's population-based data. So people forget that randomized clinical trials are done on a very select group of patients, which you said, but it's done at the top institutes with high volume. So it doesn't really reflect general clinical practice, but the STS database does at 98% capture. So I think the data that comes out of the database is very important. For everyone in the audience, there's nothing standing in the way for you to become STS members. You could do it right now on your phone, just become STS members. But whether or not you decide to be a participant in it is entirely up to you. I would challenge you and say that you should be following your own outcomes anyway. And the STS database may give you a platform on how to keep your own data, in which case you already have a head start in looking at your own quality outcomes, which I'm sure your hospital is going to be particularly keen on. In the United States, we use it because we like to compete with each other. So it's very important that I have 3 stars and Dr. Bowling only has 2 stars because I'll bring it up at dinner every day. But outside of that, I would challenge you to go ask Yoshi what would make a good proposal once you do become a participant. I think the process has previously been opaque, but Dr. Badwar and Bodish and Kaneko have made it a very fair process, and I agree the PUF is very good. You get the whole data, and you can have your statistician. We've talked about your stats. Your stats, I think, are superior to what I've seen elsewhere, and you can probably take a look at thousands and thousands of data very well on your own. So, BC, you want to close this session then?
Yes, Kenny. Thank you very much. It is a nice time to have a special lecture this time because we are very important situation for maintaining heart valve surgery registry. Thank you again for your excellent lecture.
Okay, so we may move on next session. The title is Tailored Approach to TR. This session we chaired by Daniel Tilang Chang and Anyok Professor. We kindly invite our chairperson to proceed with this session.
He wants nothing more than Yeah, and once you start participating, then you could submit research. All right.
Should I open the session or you start? It's okay. Yeah. So, start? Okay. All right. So let's continue to the next section. So welcome everyone to the section 2. Now we're talking about to tailor to the approaches to TR. So we have our panels ready here. So because of the time, maybe we just get started with the program. Now, so the first talk, let's talk about the, sorry about that, I'm on the wrong page, sorry about that. So now, the first talk is a PPM-related tricuspid regurgitation, the indications and techniques of surgical procedure by Dr. Zach Lee. So please.
Thank you for your kind introduction. And these will be the objectives of my talk today. So the majority of TR is functional, and among all causes of TR, pacemaker or ICD related TR is relatively rare, but the incidence is increasing because cardiac implantable electronic devices have seen an exponential increase in implantation rates over the past 2 decades. And in 1950s, pacemaker was just starting to be developed, and at that time it was used only temporarily for postoperative heart block. But after development of pacemaker generator with battery, now more than 1 million pacemakers are implanted yearly, and kind of by default, ventricular pacing leads and ICD leads have to pass through the tricuspid valve. And these leads are placed in the EP lab under fluoroscopy, and there's not really regular endocardiac imaging. So in 1974, there was a first case report of TR caused by pacing lead, and it was diagnosed by a murmur when the patient developed heart failure and died. And there was an autopsy that found a perforated anterior tricuspid leaflet by the pacing lead. And after that, and fast development of diagnostic technology of echocardiogram, lead-related TR slowly become more recognized. And due to the heterogeneity of a methodology and population, studies have reported extremely variable prevalence. But the incidence of new or increasing severity lead-related TR is about 20%. And the overall prevalence seems to be stable over time without any major shifts. This is our institutional data from our echo lab, and it shows similar prevalence. So about 20% of the patients had significant TR after a pacemaker implantation. So quickly, let's talk about the nomenclature. And this is a proposed system for describing the causality of the lead in TR. So if you look towards the right, there's something called lead-related TR. And this is how we describe TR that's directly caused by the RV lead or pre-existing TR worsening following lead insertion. And when you have imaging that clearly shows lead leaflet interaction, then that's also called lead-related TR. And on the left, there is lead-associated TR when there's no clear causative relationship between lead and TR. So what are the risk factors of this disease? This is one paper that compared 1,000 patients with and without RV dilatation at baseline. So if you have a normal RV and you are getting a pacemaker lead, about 1 in 4 patients will have worsening TR by at least 1 grade. And if you have a dilated RV, that actually doubles. So almost half of the patients have worsened TR by more than 1 grade. And if you just look at prevalence data, about 2/3 of these patients will have moderate or greater TR. And the progression of TR in these patients is an independent predictor of 10-year survival as well. So that's one risk factor. That if you are putting in a large RV lead in someone whose RV is already dilated, you should know that there's a good chance that their TR will progress over time. And there are other risk factors that have been proposed up there. So if a patient has more than 2 leads, then the greater risk for TR may be. And there are some clinical factors that are associated with TR progression, such as RV dilatation, permanent AFib, pulmonary hypertension, and previous cardiac surgery on left heart valves. And previous lead extraction and lead placement technique, all tricuspid valve passage angle, position, and leaflet interaction are also proposed as risk factors. And the mechanisms for lead-related TR is complex and usually multifactorial. So when you have a lead in there, there's going to be mechanical interference touching a leaflet, preventing the leaflets from closing properly. And there can be other mechanisms, so you can have pacing-induced TR just by the dysynchrony between the ventricles.
Or you can have valve dysfunction following lead extraction or endocarditis. And then chronic pacing of the RV. You can get this kind of RV failure and dilatation and remodeling. And if you just focus on the mechanical interference component, then it gets even more kind of complex. So if you have impingement, so direct contact of the leaflet preventing coaptation during systole as definition. And you can get adherence where lead gets stuck to the leaflet and the subvalvular apparatus due to fibrosis over time. And you can have perforation or laceration during placement or extraction of the lead, or entanglement of subvalvular apparatus leading to tethering. So these are the mechanisms that surgeons usually see when they operate these patients. And this is a case of a 63-year-old lady who had heart failure symptoms and previously had permanent pacemaker implantation. You can see the right atrial and right ventricle lead in chest X-rays. And the echo shows severe TR with huge dilated right atrium and right ventricle. And there's a pacemaker lead passing through tricuspid valve. And in 3D echo, you can get the image that's very close to operative finding. And in this case, the mechanism of lead-related TR was adhesion of a pacing lead to septal leaflet of the tricuspid valve. And this is a case of 79-year-old gentleman who had atrial pacing lead implantation 6 years ago. And you can see atrial lead placed in the right atrium in his chest X-rays, and there's no right ventricle lead passing through a tricuspid valve. And on his echo, severe TR and moderate eccentric MR was observed. And there's no pacemaker leads in echo, but the tricuspid valve annulus was dilated. So preoperatively, the exact cause of TR was thought to be annular dilatation rather than the pacing lead. But in operative finding, you can see that atrial lead was directly attached to the septal leaflet, preventing coaptation by retracting the leaflet. So the atrial lead can also cause significant TR. And this is a case of cold and papillary muscle rupture after transvenous lead extraction. You can see the papillary muscle head in operative finding right here. So sometimes we can face tricuspid rotation after a transvenous lead extraction. So lead-related TR can be diagnosed with echo in most of the cases, and although conventional 2D TTE has limitations in its anatomical assessment of tricuspid valve, some of these limitations can be overcome using 3D echo. So the 3D echo substantially improves the determination of the mechanism of valve dysfunction and is feasible in almost 90% of the patients with CIED leads. And with TEE interrogation, you can identify the leaflet anatomy, lead position and course through the tricuspid valve, and lead leaflet pathology as well. And with this accurate diagnosis, we can decide which treatment option is best for the patient. And what about the treatment? Looking at the statements and recommendations of guidelines, the treatment strategy for severe TR caused by CIED is still not standardized. But according to ESC and ACCAH guidelines, repair of tricuspid valve is preferred over replacement unless there is marked dilatation of the annulus or intrinsic disease of the tricuspid leaflets. And in presence of CIED lead, the technique used should be adapted to the patient's condition and the surgeon's experience. And the only contraindication to surgery is severe RV dysfunction and pulmonary hypertension. And heart team approach is obviously required to manage these patients to decide whether the patient is a candidate for lead extraction or surgical candidate or transcatheter treatment. So these are surgical techniques proposed in lead-induced TR. So usually annuloplasty ring implantation is required with or without lead flap procedures. And relocation of the lead inside or outside the ring is always necessary. And in case of no definite lead-leaflet interaction, you can see the free-floating lead without any impingement and adherence, and huge annual dilatation. Sometimes annuloplasty alone can be performed. But in this case, TR can recur because of the remnant, the pacing lead. So this is a very interesting study published from Patrick McCarthy in 2004. This was a large series from Cleveland Clinic. And they found an association if there is pacemaker leads there, there's a higher recurrence of tricuspid regurgitation. So I think when repair these patients, we have to completely remove the lead or do something to fix or to relocate the lead to prevent lead-leaflet interaction in the future. So in many cases of a lead adherent, mobilization of lead from the valve and repositioning of the leads and closure of the clefts are usually performed. So in this case, you can see a lead adhere to septal leaflet. So lead was carefully mobilized from the tricuspid valve. And in this step, you should be very careful not to injure leaflet tissue or subvalvular structures during mobilization to raise the possibility of repair. And the saline test shows good leaflet quality. And annuloplasty sutures are placed and the ring is implanted. And after saline test, the regurgitation is not severe, but the lead is relocated and fixed with sutures. And then you can see the very good result. And this is another case for lead impingement operated by Professor Jae-seok Yoo. And you can see the lead impingement in anterior leaflet this time. So lead was mobilized from anterior leaflet carefully. And to fix the dilated annulus, the annuloplasty sutures and rings were implanted. And the lead was relocated to anterior septal commissure with a simple stitch. And after saline test, you can see a small leak from the central. So central edge-to-edge suture is placed, which I also use a lot in many cases for tricuspid repair. And actually, we have a lecture planned tomorrow morning by Professor Yu, so we'll talk about it at the time. And the final test shows a very good coaptation. And the most definitive surgical management of these patients is the complete removal of the RV lead. So in this patient, the two RV leads are placed and it was interfering tricuspid valve coaptation. So removal of the pacing lead from RV, and then annuloplasty was performed. But in this case, we have to put epicardial lead implantation. So It's more complex. But after removal of the lead, you can see very good coaptation here. So what's the clinical implication of this lead-related TR? There is accumulating evidence that TR may not be as benign as initially thought, and TR of moderate or greater severity is an independent predictor of mortality and hospitalization for heart failure. And it is same even when adjusted for left-sided dysfunction and pulmonary hypertension. This is a retrospective study looked at about 239 patients actually, and they found a relatively high incidence of pacemaker-induced TR. And if you look here at the distribution of the TR grade, pre-implantation of the leads, you can see in the blue. These are baseline values, and most patients had less than grade 1 TR. Whereas after the lead was placed, you can see in the green a higher incidence of grade 1 and 2, and even some grade 3 or 4 TR. And one of the most dramatic findings in this study was that tricuspid regurgitation, as we know, is not benign, but when it's associated with devices or lead-induced TR, here they actually found that significant TR after these leads were implanted showed lower survival and higher incidence of heart failure. And this is a large longitudinal single-center cohort looking at more than 58,000 individuals. And the prevalence of significant TR was higher in patients after permanent pacemaker placement compared with those without permanent pacemaker. And among patients with a pacemaker lead, the presence of significant TR was associated with increased mortality. And this is our institutional study published by our cardiology colleagues. And the prevalence of lead-related TR was about 10% in this study population. And they found that the occurrence of lead-related TR was associated with atrial fibrillation and a history of open heart surgery. And it was associated with worse overall cardiovascular outcome. And in the subgroup analysis, according to the history of open heart surgery, the clinical impact of a lead-related TR was consistent in patients with or without a history of open heart surgery. So they suggested that the echocardiographic surveillance of TR in patients with permanent pacemaker should be performed in these patients. So in summary, worsening TR after either permanent pacemaker or ICD is an emerging clinical challenge and is relatively common, and only recognition of this disease is essential in guiding treatment. And proper surgical techniques should be performed according to the patient's underlying comorbidities and mechanisms of TR and RV functions. And it carries significant clinical implications and associated with increased risk of heart failure and mortality. Thank you very much for your attention.
Thank you, Dr. Lee. This is a beautiful review and a talk on this. So we are going to have some discussion time first, since we have quite a diverse topics in the following talks. So may I invite the panelists? Do you have any questions for Dr. Lee first? Yes, please.
Well, thank you for your fantastic speech. And I have two questions. First one is that maybe surgeons here may have different ideas, but after mobilize the leads, where do you put those? Where do you relocate the leads to? The second question is, if it changes every time by the case by case, then like what are the considerations we have to keep in mind to determine where to put those leads in between?
Usually the leads are placed in the posterior septal or anteroseptal commissures, and it depends on the curvature of the lead. That if that is toward the apex, then you should put it in posterior septal commissure, and if it towards the septal side, then it's better to put
interceptor commissure. So it's usually according to the curvature of the natural curvature of the lead placed previously.
Yes, please go ahead.
Thank you for your great lecture. As you mentioned, PPM-related TR is generally associated with very poor prognosis. In patients scheduled for left-sided valve surgery who present with just mild TR, looks like lead-associated TR, and do I have to see the T-valve?
Yeah, you better you better take a look at it, and then if there is leaflet interaction or impingement or the entanglement or adhesion to leaflet or the valve apparatus, then you better fix it when you do left-sided valve procedure.
When I open the RA, there's no interaction between the lead and leaflet. I have to put the lead on some space.
Yeah, if you just leave there, then it can induce develop TR over time. So yeah, you better fix it to relocate the lead, or if the tricuspid valve annulus is dilated, you should do the annuloplasty procedure as well.
Thank you, because next week I will have this patient, so I want advice from you.
Thank you. This is an interesting question. Can I raise a small poll here? Because there are no consensus. Where should we place the pacing lead during the mitral valve repair? So my personally preference is to place the leads outside of my annuloplastic ring. So I see, Dr. Lee, you show some cases that is still inside there. Can I ask the ortho surgeons, would you prefer to place the pacing lead outside the annuloplasty or inside? So anyone prefer to be outside the annuloplastic ring? Thank you. How about inside? Oh, I would say half and half. So epicardial. That's the third option. Thank you, Yusi. Okay. Because of time, maybe we can save more discussion later on. Okay.
Let's move to second topics. The title is Unrepaired Tricuspid Valve, the role of annular dimensions on tricuspid regurgitation progression, by Dr. Kim Ho-jin, Asan Medical Center, please.
Good afternoon. I am Ho-jin Kim from Asan Medical Center, and today I will briefly discuss the role of annular dimensions or tricuspid regurgitation progression and in patients with unrepaired tricuspid valves. So according to the STS registry, including nearly over 90,000 patients, the prevalence of a moderate or severe tricuspid regurgitation is about 25% at baseline in patients undergoing mitral valve surgery. And in this large cohort study on DMR patients, if you look at the left graph, the severity of tricuspid regurgitation is associated with a worse survival. And notably, if you look at the right graph, the detrimental effect of tricuspid regurgitation persists even after mitral valve surgery, suggesting that tricuspid regurgitation may need to be addressed more aggressively at the time of mitral valve surgery. It is well known that TR progression is linked to annular dilatation, leaflet tethering, and RV remodeling, and atrial fibrillation also contributes by just causing RA enlargement and annular dilatations. And several observational studies evaluating the TR progression after mitral valve surgery shows that TR progression is not rare and raised between 10 to 25% during follow-up. And again, tricuspid regurgitation progression is after left-sided valve intervention is associated with higher risk of mortality and heart failure hospitalizations. Even in the cohort of aortic valve disease, preoperative tricuspid regurgitation, even if it is mild, was an independent predictor of adverse survival after AVR, and this highlights the systemic impact of TR on across the valve populations. So I briefly reviewed that pre-op TR is associated with a worse survival. However, the question is, if T-valve surgery, just correcting TR, just conveys benefit or restore lifespan? Several retrospective series from our group in the cohorts with mild or moderate TR undergoing mitral valve surgery shows that concomitant tricuspid valve repair was not associated with the survival benefits. However, in a study published in JAG in 2015, concomitant tricuspid valve repair was associated with a greater freedom from tricuspid regurgitation and favorable RV recovery. And according to the 2020 ACC HA guideline, TR during left-sided valve surgery is class 1 if severe TR is present. And it is class 2A in case of a progressive TR and annular dilatations greater than 40 millimeter or signs of RV failure. And in this key randomized trial published in New England Journal of Medicine in 2022, it randomized a patient with less than severe TR but annular dilatation greater than 40 millimeters. At 2 years, a concomitant repair reduced tricuspid regurgitation progression, but there was no difference in mortality, and this has influenced the guidelines. So in 2025, just ESCTS guidelines just published 2 weeks ago. Just concomitant tricuspid valve repair is class 1 in severe, of course, and class 2A in moderate, regardless of the annular dimensions, and is class 2B in mild if annulus is greater than 40 millimeters. Usually, it would be generally well accepted that tricuspid regurgitation severity is proportionate to tricuspid annular diameter. However, if there is still an ongoing debate when tricuspid regurgitation is not significant in patients with a dilated annulus. So in this study, just performed by Dr. Dreyfus in 2005, he measured the annular size intraoperatively and performed the annuloplasty if diameter is greater than 70 millimeter, which seems to be quite generous. And they concluded that a annuloplasty based solely on annular diameter improved the functional state, although survival benefit was not demonstrated. However, in his paper on nearly 1,200 patients undergoing DMR repair, Dr. Tyrone David showed that recurrent or new tricuspid regurgitation after mitral valve repair is not common, as showed on the right picture. And he showed tricuspid valve repair was not associated with improved survival. What's more interesting was in the next pages. This meeting paper was quite harshly discussed among Dr. Dreyfus, Dr. David Adams, and Dr. Tyrone David. And Dr. Dreyfus argued that tricuspid regurgitation is not reliable, and annular size is a more reliable indicator for repair, which Dr. David reluctantly agreed. However, in his following paper on 312 patients with an annular diameter greater than 40 millimeters, who underwent a mitral valve repair, he showed that new or persistent regurgitation rate was not significant, and annular diameter greater than 40 millimeters is not associated with the development of post-op TR. And meanwhile, in this paper from the Northwestern, the tricuspid regurgitation progression was shown to be more closely associated with the preoperative atrial fibrillations, and the threshold for annular dilatation for progressive TR was suggested to be 45 millimeters. On the other hand, all the annular size to indicate for intervention are mostly from measurement using echocardiography or interoperative measurement, which is sometimes subject and may prone to inter-observer reliability. On the other hand, the other imaging modalities such as CT scan may provide more accurate or reproducible annular measurement than echocardiography, and more increasingly used for preoperative assessment in transcatheter tricuspid valve intervention. So in this busy slide showing the flow chart of our pilot study, I identified patients with mild or moderate TR undergoing mitral valve surgery, and after just applying for exclusion criteria, and among 1,100 patients, we included 610 patients whose pre-op multi-phase CT data is registered in our radiology core lab, who are eligible for retrospective tricuspid valve annular measurement. And mean age was 60, and 49% was female, and tricuspid diameter was 44 millimeters, and 73% had a diameter over 40 millimeters. And among these patients, significant TR defined by TR progression by 2 grades or the presence of severe TR was present in 51 patients, which is 8.4%. So this picture briefly shows how we measure tricuspid valve diameter. And in this paper, in this TV shows that the probability of a TR within 10 years at around 10 to 12%, but it starts to slightly increase at around 40 millimeters, which is quite aligned with the current guidelines. So to conclude, tricuspid regurgitation in patients undergoing mitral valve surgery may not resolve after correction of mitral valve disease and is associated with the increased long-term mortality. However, tricuspid valve repair during mitral valve surgery improves RV function and remodeling and prevents TR progression. However, survival benefit remains controversial. And new other imaging modalities such as CT or MRI may help better define patients who could benefit from tricuspid valve repair. Thank you for your attention.
Nice presentation, thank you. Any other comment from the panelists? Okay.
Thank you for your wonderful presentation. I have a very simple question. Do you measure the TV annulus by yourself?
Not actually. So here's the thing. So in our echo data, they do not provide any tricuspid valve. They do not provide tricuspid annular size. So sometimes when I see the patients with a TR at grade 2 or 3, I just eyeballing, okay, it looks dilated, and I just put a ring.
Okay. Yes.
Hojin, thank you for running with me the other day. And a tremendous talk and also a very controversial subject. I would like to say I was a mathematician before I went to medical school. And we had a saying in mathematics, and it's true, that the absence of proof is not the proof of absence. So just because we can't see the difference very clearly at 1 year or 2 years doesn't mean that there isn't a difference. So in every study that you showed, even including the one that we did in CTS-NET, even at 1 year, those patients who had a tricuspid annuloplasty at the time of their mitral were slightly better. Now, granted, it did not reach P equals 0.05 and so on like that. So we said they're the same, but they're probably not the same. And your very nice study shows that tricuspid patients do poorly very slowly. And we probably will have to wait 10 years for the answer from the New England Journal paper. So therefore, just because we can't show it statistically right now doesn't mean that it's not a biologic phenomenon. And I think you're right that we should continue to probe this problem. And I think I'm very aggressive about doing these patients. Thank you for your information.
Thank you very much. Can I ask a question, Mayor? Yes.
Yes.
So, what is your strategy to find out the mild tricuspid regurgitation less than 45 millimeters tricuspid annular diameter, and the grade is mild to moderate? What will you do?
It is really controversial, and just before I see the data that just average diameter of a tricuspid annulus is around the 44 millimeters, and Dr. Bowling yesterday visited our hospital and gave a brief just lecture to our residents and trainees. He mentioned that just annulus, T-valve annulus size of the normal size is a 29 millimeters. It's already quite dilated, and over 70% of patients in our cohort, even if it's a mild or moderate, and is 40 millimeters. So I think I thought I have been quite aggressive so far in just trying to correct the TR, but I think I should be more aggressive just in just correcting the TRs from now on. Also, the other thing is in our echo data, they do not provide any annular size or something, so it's really just hard for us to just evaluate should I put the ring or not. So this is what I would just discuss with our cardiologist if they can provide such information just for us to just better define the patient.
If I can make a comment, Dr. Kim is exactly right in that the normal size of the human annulus is almost proportional to your thumb and forefingers. I'm the tallest person in this room, and my annulus is only 28 or 29 across, and that is the median size in humans. By the time it gets to 4 centimeters across, there is a reason that is. 4 centimeters is almost 5 standard deviations away from the median in a human. There is a reason why it is so dilated, and not a good one.
So a little counter argument to it is the paper that you showed from Northwestern. That paper, all the patients had tricuspid valve repair. So that paper that you showed, all the patients had tricuspid valve repair in that group at the time of mitral valve repair. And you saw that if you have AFib, 25% recurred over time. So, you know, that's very high if you think about it. And goes to Dr. Kim's talk that, you know, even with tricuspid repair, the long-term outcomes are not great. So what's the mechanism of this? And are we doing any good by repairing if 25% is recurring?
As my memory is concerned, Dr. Kim, this morning you talk about your approach to the mild, moderate, or some normal tricuspid annulus. You still try to the annulus repair with ring, right? You have a comment on that?
Yes, actually, the size of the tricuspid valve I think it cannot confirm the T valve is normal or not. So, actually, we cannot confirm the disruption of T valve annulus or T valve the integrity. So usually during the mitral valve replacement, especially rheumatic mitral valve replacement, the routinely do the ring annuloplasty, and because we can do ring annuloplasty so safely, and currently I think less than 10 minutes, because currently we use the auto-tying device at the end of the surgery. So so it is not a big burden. So I'd always routinely do the ring annuloplasty.
Dr. Bowling, he talked about the normal size of 28, 30. So what size do you use in no or mild tricuspid regurgitation? What size you choose?
Actually, I think the intercommissural distance usually if my memory is correct, usually the 26 to 28 ring
26 to 28.
Yeah, mostly it's more than around the 90% of my patients. Yeah.
You are the Korean.
Yeah.
He's the American, right?
We have some questions from the floor.
Can I ask you
Professor
something?
Jie.
Hojin, I know you are a very active T-valve repair surgeon, but the decision to repair or not is multifactorial. So is there any influence of the etiology of mitral valve disease, such as rheumatic, degenerative? And the second one is age of the patient. We all know the T-valve repair itself does not increase the survival rate. So we should look at the long term. So for the younger patient, more actively repair, and elderlies, just neglect it. Is there some idea about that? Age and etiology.
Thank you for the great questions. And to be honest, I haven't thought about that, but you're very right. And in case of older patients, in case it comes to a mild or moderate TR, I may have skipped it. But definitely younger patients, I will be very more aggressive just to repair.
Just comment, Dr. J. Very good question. Because I have several studies on left side valve disease, we are doing the moderate TR every time. So we study the mild TR according to the left side valve disease. Double valve disease first, and mitral valve replacement, that is rheumatic disease. Lastly, we did the mitral valve repair, that is a degenerative disease. Double valve disease, rheumatic disease, after 10, 15 years, valve is not normal. Two leaflet, two mechanical valve become stenotic or subaortic panels. So in that case, no the survival benefit, but late follow-up, more than 10 years follow-up, some event is higher, but survival even more than 10 years follow-up, survival no difference. In mitral valve disease, that is rheumatic patient, mitral valve replacements. There is no event is no difference between in mild TR, but late follow-up, we look at the just moderate TR after recur. Moderate TR incidence is increased, but survival event is not except moderate TR. In mild TR, the mild TR during the mitral valve repair degenerative disease, no difference. Even more than 10 years, 12, 15 years follow-up, no difference in survival event, TR recurrence more than moderate. So that is we are doing the quite aggressive approach. Do not leave preoperative moderate TR, always repair. But repair technique, is risk and benefit always think about. If we have heart block less than 1.5%, even double valve, mitral valve replacement, MR repair, we have some mitral degenerative MR, we don't have to, but moderate TR we have to do. Because if the patient is just 60 years old, the patient survival until 8 years. But after 15 years, the patient has some discomfort during follow-up in outpatient clinic, increase diuretic dose, increase some medication. That's my opinion. Yeah.
A short comment, Dr. Kim, because many surgeons need some question, but tomorrow afternoon we have another time to discuss this problem, right? Short comment, please.
Thank you for a great comment, and I entirely agree that the impact of mild or moderate TR may differ just among the etiologists. So we need, I think that we need more follow-up. Just mentioned by Dr. Bowling, just in the CTS study, is only 2 years, and in the end of the conclusion, he said that you need more follow-up. Yeah.
Thank you, Hojin.
Thank you.
So let's move on. May I invite Dr. Sasuke Fukushima to give us a talk on struggling in surgical repair of massive or torrential TR.
Thank you very much. Thank you very much for inviting me. I'm actually struggling to do the surgical repair of TR. So I'm going to show you why I'm struggling or how I'm struggling. So give me any advice or suggestion. All welcome. Thank you. Does it move? No? Yes. So etiology in the severe TR in adult is variable. Is epistemic anomaly or the atrial fibrillations or pacemaker lead, as the previous talk. And myocardial biopsy that is typically after transplant or post-valvular surgery we will frequently see. And trauma is very important. And the risk of the surgery is heart function and other organ dysfunctions. So the contents of this talk is I will show you the institutional outcomes of the severe surgical outcome of severe MTR. I compare to the published outcomes of transcatheter approach, and I will show you how I have optimized the repair, or how I am optimizing the repair of the severe MTR. And then lastly, I will propose a surgical scope and perspective of severe MTR in my institute. So I'm going to show you the surgical outcome of that severe MTR in my institute. In the last 15 years' time, we have about 150 cases, which is about 1% of all cardiac surgeries as in the database study. So 1% of the cases, but it's very important, I think. So endpoints are all-cause mortality, and the second endpoint is the TR grading. This is a study presented by Dr. Sakurai, who is a fellow of my team and published in the WTS this year. And background of the patients I will show you. The mean age is about 70 years old, and NYHF 3 or 4 is about 15 in the severe or 35% in the massive torrential TR. And there is like 80% have atrial fibrillations. And the previous surgery, the cases was 40% in severe or 30% in massive torrential TR. So the primary TR is about the quarter, and the rest of them are secondary TR. And mitral involvement was about 50%. And we did majority of cases will repair, but 20% of massive torrential cases will be replaced with tricuspid valve. And repair, we did angioplasty, is majority of case, most of the 100 cases of repair, and the other technique was done in the 50 cases of massive torrential. And some cases I did repair, but converted to replacement of some cases of massive torrential TR. And we did mean thoracotomy is about 20% cases, and mitral valve we did about 3/4, MACE procedure about 20%. And in hospital death was 2 cases in the massive torrential TR. And this is a grade of TR. And in the 1 year after the surgery, the severe cases, about 50% is mild, and 40% is moderate. And massive torrential cases, about 70% is mild, but what quarter is moderate. And in 5 years' time, the TR is going up. About 60% is moderate, and about half is moderate or moderate severe or severe in the massive torrential cases. And compared to the transcatheter approach, 1 year, 2 or 3 years is better than surgery is better. But I'm not really happy with that. The surgical results is like 30%, 60% is moderate in 5 years' time. That is, I'm not happy at all. So that's why I'm struggling, I said. And survival is not bad. Like 90% survived in 3 years' time, and 7 years' time is about 80% is survived. It may be better than the transcatheter things. And I analyzed the predictive factors of mortality post-TR surgery is long-term, is elevated hemoglobin No, is less hemoglobin is a risk factor of the mortalities, and elevated creatinine is risk factors, and a BNP, no, not BNP, ejection fraction is risk factors of the mortality. So the massive or torrential TR was not the risk factor of the mortality in my cases. So I summarized the TR surgery in my institute. The surgical repair was feasible in majority of patients having severe TR with comparable prognostic outcomes to the transcatheter approach. And surgical repair is advancing by minimal invasive approach and adjunct procedures to the ring annuloplasty. And the selection of surgery of transcatheter should be tailored to patient needs or updated. That is important. So now how I am optimizing surgical repair for the severe TR. So my conclusion now is only annuloplasty is not enough in a severe TR. I need more adjunct procedures for the tricuspid valve. Is a published procedure, a lot of published procedures. One is a papillary muscle relocations as presented in wet lab this morning, or suspension, or this manipulation of the papillary muscle. And caudal replacement is good. And another thing is the leaflet augmentation. We can augment anterior leaflet, posterior leaflet, septal leaflet. So I'm going to show a case. The case one is a 75-year-old man. He has a traffic accident 19 years ago, and ECG abnormality detected 2 years ago. And he has a shortness of breath on exertions. Have a look at the echocardiogram. There is a prolapse of the septal leaflet here. So there is the severe TR, vena contracta width is 11 millimeter. So the prolapse of the clearly septal leaflet is prolapsing here. There is a severe TR. So I did robotic surgeries. In the robotic approach, we can see the anatomy of a tricuspid very clearly. I love to see the anatomy first by myself. I can control the retractor and camera by myself, so I can look at the tricuspid valve very clearly. There is a papillary muscle, two papillary muscles that has this guy. This is the posterior leaflet. That's a normal valve actually, and papillary muscles. And there is a septal leaflet here. There is anterior side of the septal leaflet is okay, but the posterior side of the septal leaflet is prolapsing. So I put the nail coder in the posterior papillary muscle. And in the robot, this length, this length is 5 millimeter. 1 millimeter is here. So the papillary muscle is about 3 millimeter, very small. So very fragile, so very dangerous, you can see. So we put the two stitches. This is, I think, the CV5, the Gore-Tex sutures to the posterior papillary muscle. And then two stitches are linked to the posterior side of the septal leaflet. So there is a chordae of the posterior side of the septal leaflet was ruptured by probably due to the traffic accident. So it's a very fragile leaflet actually. Normal leaflet, I think. So I put the water test first. And have a look. The leaflet of the anterior leaflet and the posterior leaflet, and is basically the normal. This is just the pathology, just a caudal rupture. So I put the ring in. Then need a fine adjustment of the length of the caudaes. Like this. And do the test first. Do the test again. And then that looks fine. That's beautiful. That's like a normal tricuspid valve. So that's fine, that's good. So it's an intra-off TEE, no TR. And that's day 5 before discharge. This is just a trivial TR. That looks fine. He's doing very well. And the second case, very different story. He's a 77-year-old man, had a mitral valve repair and MACE procedure 12 years ago. And he had a AV block, and the pacemaker was implanted 4 years ago. Then he had a severe TR, pacemaker related, as she said. And the shortness of breath from exertion she had, and the post-preoperative transesophageal thoracic echocardiogram, you can see the severe TR. Ejection fraction is 42%, but the mitral is okay. And that is actually the pacemaker related, but the right ventricle is very dilated. And again, I did robotic approach. You can see the pacemaker lead attached to the posterior papillary muscles. This is the posterior half of the septal leaflet. So I do the tricuspid surgery by the cross clamp always. So they cut the lead and have a look at the valve. Valve was very dilated due to the tricuspid regurgitations. And this is a posterior leaflet. This is anterior leaflet. The septal leaflet is short now. And there is a lot of space here. So what I do is cut the stem of the posterior leaflet, not septal leaflet, from the commissure to commissures to make a mobilization to the of the septal leaflet. And if there is a secondary cord here, I cut them off, but this case has no secondary cord here. So I put the fresh autologous pericardium, like the big size. And need to suture the pericardium by the single stitch, or I do the U stitches, no contingent suture that make the valve smaller. So I need to put about 20 stitches here. Takes very long time. But it's very important, I think. I have done the landing sutures, but which was not good. So I now put the single stitches, multiple single stitches, 20. Takes a long time. So then you can see the water test. This is actually the pericardium. The shape of the tricuspid valve is changed a lot. And then to put the ring in and do the test again. Have a look. And the shape of tricuspid valve will change a lot. Like this is an anterior leaflet, posterior leaflet, and septal leaflet. But there's no leak. So this is a TEE. Actually, you can see the pericardium here, but there is no leak actually. On day 5, there is the mobilized pericardium, but there is no leak actually. So this is a way how I do the tricuspid valve repair for the severe or massive TR now. But I have to see the long term. I've done about 10 cases, but it's all good so far. But I haven't seen the 1 year's echo, so I need to have a look. But anyway, so the surgery and catheter is a discussion, is now. And I think it's a congenital or trauma, the surgery is the first. And pacemaker lead, catheter is not good. I think it's unbalanced, the pathologies, and surgery is better. But the post-valvular surgery, atrial fibrillation, is a risk of surgery may be very high. The catheter may be good. And the sternotomy versus mix or robotics is another discussion point. And congenital surgery is Epstein's anomaly. Sternotomy I think is better because Da Vinci takes too long time to do that. I've done that, but it takes too long. And the pacemaker lead is atrial fibrillation. We can do the Da Vinci's. And post-valvular surgeries, Da Vinci is good. And trauma is basically the young cases, which the Da Vinci is the best idea. So this is my team. Special thanks to the Dr. Sakurai. Now he's at Science Institute of Tokyo. He's very well, very good. So this is my team of the National Center. Thank you for your attention. Thank you.
Thank you. Thank you, Dr. Fukushima. So we open the discussion now. May I invite the panelists? Any questions?
Yeah, thank you for a great lecture. I have two questions. And first is, when you're facing the coaptation depth over 10 millimeters or severe tethering in the tricuspid valve, how do you decide between repair or replacement in tricuspid valve? And second question is, how do you management of right ventricular function when the right ventricular failure is occurred after tricuspid valve repair?
Thank you. This is a very important point. The first is repair versus replacement. I basically do the repair every patient. But when the case is very old, is not tolerable for the cross clamp, these things, I do the replacement. Otherwise, or some cases I encountered is that there is no leaflet, the anterior leaflet was towed out. We have to do the replacement. But basically, all the cases, I try to do the repair. And the second question is the management, right ventricular dysfunction after the surgery. That's very important. I put dobutamine for a long time, or like 1 month, something like that. I used Arvad, it's 1 or 2 cases, but it's not good. It takes too long in hospital treatment. You do a dobutamine. And in these cases, we shouldn't do the cross clamp to preserve the heart functions. That is very important.
Another panelist, Dr. Kim.
Yep. Yes. Thank you for your wonderful lecture on repair of massive TR. I have a different question. I noticed in your cohort of patients, a lot of patients had atrial fibrillation, but you only performed the Maze procedure in 20% of patients. What is your opinion on the impact of atrial fibrillation on the recurrence of TR? So,
basically, I do the Maze procedure try to do the Maze procedure all patients. But in the case of the severe massive TR, is left atrium too dilated. Sometimes it's like from already the pacemaker for the bloody AF. These cases we don't need to do the Maze procedures. That's why the Maze procedure is 20%. The case background is very bad. That's why I didn't do the Maze procedure at all. These cases, the Maze procedure is very good. If the cases have a good chance to recover the sinus rhythm by the Maze procedure, I do. Very important, I think.
Okay. Yes, Dr. Bowling.
Very nice series. I think this points out a very important point that we need to educate our cardiology colleagues about when to send a patient to surgery. Those patients with torrential TR, 2 years before that, they had massive and they needed surgery. And 5 years before that, they had severe TR and they needed surgery. And it is unfair to us to be faced with these patients with torrential TR where you have to say, is the RV too sick? Is this too far gone? And so on. When 5 years before that, you would have had a very easy repair and you would not have struggled with it. So I think it's up to us to educate our cardiology colleagues when to send these patients to us for tricuspid valve repair. Very important.
I asked, very important, Dr. Bowling, thank you very much. And I asked cardiologists if the cases have two kinds of diuretics sent to me, like these things. Another important thing is to repair the valve. It's very important for the massive potential and have a trust of the cardiac. If the cardiologist thinks the surgical results are very good, they send us. That is happened in the mitral valve repair. The same, I think. So need to repair the transitive or massive TR. That is a way how to. Yeah, exactly.
Last question.
Yeah. First of all, I deeply appreciate your accepting our invitation to come over to Seoul to join this meeting. And I really enjoyed your presentation, including nice data and nice video clips. And then my question is short. So you showed patch augmentation. And then can you share your idea on the potential kind of degeneration and the limited durability of patch, autologous pericardial patch as compared to the bioprosthetic valve? Because whenever we see through aortic valve or mitral repair, patch augmentation has some kind of is a risk factor for late development of valve dysfunction. What do you think on the use of pericardial patch for such a case?
Thank you so much. Thank you so much, Erin. Very important point. The pericardial patch is kind of the discussions always. And I don't treat where the glutaraldehyde, that is fresh living the tissues. So it doesn't degenerate too fast, I think. And this tricuspid valve is the low pressures as compared to the aortic or mitral. So the less chance of degeneration, I think. So the durability of the autologous fresh living pericardial patch lasts long, I think. But I need to look up. I need to see.
Okay, thank you very much.
Thank you.
Nice
Thank you
presentation. Let's hurry up to the last paper. I'd like to invite Dr. Cho Yang-hyun. He will talk about the managing tricuspid regurgitation in left ventricular assisted device patient. Please, Dr. Cho.
Thank you for kind introduction, Professor An. Thank you for having me, especially as the last speaker of today. I do my best finish on time. So I don't think many of audience interested in end stage of heart failure, especially LVAD patients. But thanks to Dr. Ho-Jin Kim's talk, my talk is pretty consistent with Ho-Jin Kim's talk. So first I review the TR and LVAD things. This paper 15 years ago emphasized preoperative TR is predictor of poor outcome after LVAD. Pretty similar with left side valve surgery outcome, as you can see, mainly because of RV failure. And then there was a paper quite also many years ago showing that potentially tricuspid valve surgery may improve outcome after LVAD, especially improving RV function, but quite small single center study on this topic. And then there was another paper showing that tricuspid valve repair is helping reducing TR and durability of this TR repair goes longer than we expect, as you can see here. And then these people, researchers focused on liver function. So they thought potentially tricuspid valve surgery after left ventricular assist device implantation may improve liver function potentially lowering CBP and congestive hepatopathy. And then, however, if you go to Google Scholar or PubMed, if you look at the papers or evidences showing benefits of tricuspid valve surgery at the time of LVAD, that's almost all papers. The other papers are saying quite skeptical on tricuspid valve repair, like this. So even this paper showing preoperative TR and mortality, no difference. However, they found a residual TR. So in the patients who TR is not regressed, because most of these patients having functional TR rather than structural TR. And these people does not live long. Also quite obvious for us. And then Intermax registry, some of the audience may familiar with it. Intermax registry is MCS registry in North America. If you see this, there is a statistical difference according to the significant TR, which means more than moderate TR preoperatively. The survival is inferior to a patient having mild or no TR before LVAD implantation. But the gap is not that big that we expected. And then if you see this, in more than moderate group, whether you do repair or not, there is no difference in survival, as Professor Park mentioned on this. And then this is quite the only randomized trial on this topic, TV-VAD trial, done by Duke, done in Duke. And as you can see here, whether you do TV surgery on more than moderate TR in LVAD patients, whether you do or not, the TR generally regress. And then certainly in TV surgery group, there is less TR than no TV surgery group. But as you can see, there is no difference in RV failure in between two groups. And then this is a more recent follow-up of their trial, pretty consistent with their initial report. TR generally regress even without tricuspid valve surgery. Certainly in TV valve surgery group, less TR, but no difference in RV function between two groups. Then in this paper, they looked at the mortality, no difference. Then they look at the VO2 max, no difference. They look at the 6-minute walk, no difference. And then their quality of life score, no difference. And then right heart failure and near class, no difference. Actually, this is the data we will show tomorrow by my junior colleague. So we look at our data. We analyze 183 patients, LVAD patient at our institution. We found 45 patients, more than moderate TR. And then there was a 14 TV valve surgery group, and then 29 TV valve surgery group. Pretty consistent with the previous paper, like TV VAD trial. So TR regress in most of patients, even without TV valve surgery, but less TR in TV valve surgery group. However, but there is no difference in right heart failure severity between two groups. We show more detailed outcome tomorrow. And survival, no difference. So I don't think audience is really interested in whether we should do TV valve surgery in LVAD patients or not. But based on this experience, and we can learn from this TR repair experience in LVAD patients. So before LVAD, significant TR, definitely poor outcome. But surgical intervention, no benefit, especially on survival and probably in RV function and quality of life. And most of patients, TR regress. If there is no regression, very poor RV function, it means patient has very poor RV function and the survival may not very good. And if we transfer this experience, actually, Professor Ho-Jin Kim already discussed about this. In left side valve disease, if TR is not very severe, possibly no big positive impact, especially on survival. And isolated TR we already discussed, so I don't think I need to discuss more. So that's it. Thank you very much.
Thank you very much. Any other comment from the panelists? Okay.
Thank you for your wonderful presentation. In my opinion, the TR in the LVAD patient would be different from the TR with the left side valve disease. So, which parameters or factors are important for you to do the TV surgery for LVAD patients?
So currently, we stopped performing any TV surgery in LVAD patients. We don't care about diameter. We don't care about how severe TR is. But the problem is we honestly never seen torrential TR or massive TR, as a previous speaker shown. Most of these patients excluded at the time of patient screening for LVAD. So currently, most of centers and my personal experience, do not touch tricuspid valve.
I just wonder your patient has a poor left ventricular function, even right ventricular dysfunctional. So you try the tricuspid valve repair with a beating heart or a resting heart?
Yeah, when I do always beating heart.
Beating heart. Because the two previous speakers, Dr. Lee showed us the beating heart surgery for tricuspid valve repair, but the surgeon from National Cardiovascular Center, he has the arrested heart with robotic, right? So what do you think for the patient with right ventricular dysfunction, severe, torrential TR?
We need to respect right ventricle. We don't care LV, but we need to respect RV function, so we keep perfuse RV. And TV valve surgery, especially for LVAD patients, not very, it should not be perfect like a previous speaker's technique. Just reduce diameter, just reduce a little bit of TR. And most of these patients, multiple wires through the tricuspid valve, and the PA catheter is going in, very busy. So just put 7 or 10 stitches and ring. Sometimes just stitches around tricuspid valve annulus and tying it. That's usually my practice. Thank you.
Okay. Any other question from the floor? Yes, it's too late for the schedule, right? Okay, thank you very much, all the speakers and assistants. I will close this session, okay? Thank you.
Okay, thank you everyone. So we've come to the end of today's programs. It's finally Professor Gi-Sung and the director of this program is addressed in the closing remarks.
Members and guests, thank you for all your participation, including when at early morning today. It has been an inspiring first day to learn about tricuspid valve pathology. Tomorrow we will have many interesting topics in different scenarios. I especially appreciate our international guests, including STS members, who willingly to devote their time and effort for Korean Society and Heart Valve Disease Forum. I hope you enjoyed the evening and return tomorrow 8 a.m. Thank you again.
Thank you for everyone. See you tomorrow mornings. Thank you.
So this evening the faculty and invited speakers dinner at the Courtyard Marriott lobby, the 5:30, yeah, and the follows, okay, yeah. Actually the dress code is the commonly casual, yeah.